So let's start the thyroid cancers and then we will do urology onwards. Okay, all set already. Let's go. Men's syndrome is covered in pathology already. I already saw Dr. Sparsh's notes. He has already taught you men's syndrome. I will put some questions on men's syndrome in END then. So thyroid cancers, remember, there are actually three groups of thyroid cancers and they behave very differently. They are all very different in their behavior. The first type, the more common type, are the OG, what you call as OG, the original thyroid cancers, which are called as the differentiated thyroid cancers. Differentiated means they arise from the thyroid follicles. So they come from the thyroid follicles or the thyroid gland per se. And they are of two main types. The most common type is the papillary. This is the most common type of thyroid cancer overall. Almost 85% of all thyroid cancers are papillary. The second type is the follicular. This is the second most common type. And it has a variant which is very aggressive, which is called Hürthle cell variant. So it's a variant of follicular cancer, which is called Hürthle cell variant. It is more aggressive. Like how some of you are a little more aggressive. Like today, someone was writing on my Telegram, this is there, this is not there, blah, 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 blah. So they are all variants. They are a little abnormal. I don't know if that person has come today or not. So these are the original thyroid cancers. जिसमें most common is papillary. Okay, we will discuss papillary follicular अलग से. Then you have the undifferentiated type, in which you have the anaplastic. And anaplastic, of course, is very aggressive. Name only should tell you it is going to be aggressive. And the third type, it is there in the thyroid gland, but it is not coming from the glandular epithelium. It's not coming from the follicles. It is coming from the C cells, the calcitonin cells. That is your medullary thyroid cancer. It's not very common. Okay, medullary thyroid cancer. Itna common nahi hai. Medullary thyroid cancer is the cancer that is seen in MEN2 syndrome. Okay, so in MEN2 syndrome, very commonly, you get medullary thyroid cancer and you get pheochromocytoma. Okay, that is seen in MEN2 syndrome, MTC and pheochromocytoma. In MEN2 syndrome, you have two subtypes. You have MEN2A, where you have MTC, you have pheochromocytoma. You also have hyperparathyroidism in MEN2A. Okay, so you have hyperparathyroidism, and in MEN2B, you have those M wali cheezein, marfanoid habitus, mucosal neuromas, megacolon. So these are seen in MEN2B. Okay, but all patients with MEN2 will have MTC and they will have pheochromocytoma commonly. Otherwise, medullary thyroid cancer is not so common. Okay, itna common nahi. So let's discuss the important ones. The papillary thyroid cancer, very important. It's one of the good cancers. So till now, whatever cancers we studied, they were all very bad cancers. Papillary thyroid cancer is a good cancer to get. Why is it a good cancer? What is so good about it? So it is the most common type of thyroid cancer. It is very differentiated. The risk factor is usually it is seen in people who have received prior neck radiation. Okay, अगर बचपन में किसी कारण से you have received neck radiation, you are at risk of papillary thyroid cancer. If you are suffering from Hashimoto's thyroiditis, you are at risk of papillary thyroid cancer. But it has a good prognosis. Why? Why is it having good prognosis? Easy to treat? No, because it does not have much metastasis. It's very slow growing. So metastasis is not so common. So pathologically, it is slow growing. And you only have lymph node metastasis. Which lymph node metastasis does it commonly go to? Commonly, कौन से lymph node पे जाएगा? We studied this in head and neck in general surgery. So tumor in the neck will go to neck nodes, but this typically goes to level 6 neck nodes, which are also called as Delphian nodes. Okay, this came in FMG Gen. If I do a biopsy, obviously you don't do core biopsy, means after excision you get an appearance like this. What you see these cells with clear nuclei. Those are called as orphan any nuclei. So you see cells with orphan any nuclei. They are basically clear nuclei, and you see these nice big round things. I'm sure you know what they are. Absolutely right. They are called as Samoma bodies. And normally, if I diagnose papillary thyroid cancer, what will the treatment be? How will I treat papillary thyroid cancer? What is the treatment? हमने कल ही किया है, कल रात को. Surgery. कौन सी surgery? The surgery is going to be total thyroidectomy. Okay, only one treatment, total thyroidectomy. Sometimes you may have to remove level 6 nodes also. Sometimes. So simple. This will be the diagnosis, management, everything. It will be total thyroidectomy. In thyroid, only two surgeries. Hemi or benign if it's only on one side, and total if it's on both lobes or if it is a cancer. Keep it simple. Now come to follicular. Follicular is unique. It is seen in patients, so it is also having good prognosis only. It is seen in patients who are having long-standing multinodular goiter. So yesterday we studied diffuse goiter, multinodular goiter, solitary nodule. So if it's a multinodular goiter and it has been there for a long time, then the person is likely to get a follicular thyroid cancer. Now the thing about follicular thyroid cancer, it is also not very aggressive, but pathologically, it will give you hematogenous metastasis. Okay, so you get blood metastasis. Hematogenous metastasis very commonly to bones, like thoracic vertebra or skull. Commonly it goes to these bones because they are close to each other. So it will go to cervical vertebra, thoracic vertebra, ribs, or skull. That's where it will normally spread to. Lymph node metastasis is not very common. How do I diagnose this? Is it diagnosed on FNAC? If I do FNAC in patient with goiter, will I come to know it is follicular thyroid cancer? So this is something which can't be diagnosed. It cannot tell you whether it is adenoma or carcinoma. So when I do FNAC, I will only see the follicular cells. Whether the tumor is benign or malignant, I can't know. You don't do true cut biopsy. Kal hi to bola, true cut biopsy only one indication. Anaplastic from Riedl's. Otherwise, there is no. You do true cut biopsy, he will bleed, he will have tracheal compression, he will die. Good for you, unfortunately. Okay, so तुम्हारा गया पेशेंट फिर लाइफ से भी गया और तुम सर्जरी भी नहीं कर सकोगे. डेड पेशेंट में सर्जरी तो नहीं करेंगे. So you have to do things to keep him alive so that you can operate and right. So don't do true cut biopsy. What you are going to do is if a person has a follicular tumor on FNAC, you don't know benign or malignant, पता नहीं है. So what you are going to do is you are going to do intraoperative frozen section. Okay, intraoperative frozen. Like how you did sentinel lymph node biopsy, something like that. So what you do is if there is a tumor, You take an incision, you remove some part of the gland, send it for frozen, and if the frozen shows that it is malignant, you will do total thyroidectomy. Okay, because the problem is, how do I know it is cancer? Have a good look at this image. Very nice image. This part that you are seeing, this is all normal thyroid gland. I told you, no, all these glands will have follicles like this, acini. And in thyroid, you have this liquid inside which is called colloid. So आपको colloid भी दिखता है. So you know it is thyroid follicles. This probably is where the tumor cells are, all this. But FNEC पे पता नहीं चलेगा whether it is benign or malignant. So what you need to see is these cells. You can see this is the capsule of the gland. These cells have gone beyond the capsule. So there is a capsule invasion. These red things, they are the blood vessels. You can see in this blood vessel, even in this blood vessel, the cells have entered. These cells are entering the blood vessels. This tells you it is cancer. So what you need to see on biopsy is what is called as capsular or vascular invasion. Okay, see, understand, I am not a pathologist. I cannot teach you pathology like a pathologist will. What I can show you is how a surgeon understands pathology. So now you understand, when I see a pathology slide, how I should try to interpret it. No. So when I interpret it like this, it becomes a lot easier. Otherwise, आप थोड़ी pathology रट के जाओगे images में कैसे देखना है क्या देखना है. You should understand, if you see something like this, these are follicles of thyroid. You see this, blood vessels. This is the capsule. Tumor cells have gone beyond the capsule. So it is a malignancy. Easy way to understand it. Okay. What is frozen? I don't think, Snigdha, we can discuss it at this stage. We discussed this in breast cancer, frozen section. So maybe you can refer to pathology to understand what is frozen. I don't think this is where we can do it. After you have removed the tumor, whether it is follicular or whether it is papillary, either ways, after you have removed this tumor, post-operatively, what do you do? Post-op. What do you do post-operatively after removing the tumor? Check for mets. Chemo. I like how you said chemo, but the thing about these cancers, the OG thyroid cancers, is they are going to be uptaking iodine. So they have that capacity that anywhere in the body, if there is iodine, it will try to take it. So I have the advantage of treating them with iodine. So what I do post-operatively is I do two things. One is I check the serum tumor markers. Which tumor markers? Serum thyroglobulin. And the second thing I do is I do a whole body iodine scan. And why am I doing this whole body iodine scan? Yesterday only we discussed this, is to look for metastasis. So once I have removed the gland, if I give iodine, radioactive iodine, there should be no uptake of iodine anywhere because thyroid takes iodine nowhere else. But if he has metastasis, like metastasis to the skull, those metastases will take up the iodine and that will be seen on the scan. So yesterday when we did thyroid scan, I gave you two indications. One indication was toxic nodular goiter. Other indication was metastasis after thyroidectomy. That is this. And you cannot remove the metastasis, Mr. Abhishek. Metastasis koi nahi nikalna. You can only remove the main tumor. Right? As long as the gland is inside, even if there are metastases, iodine will go only to the gland. Once I have removed the gland, the iodine will go to the metastasis. So this helps me pick up metastasis, but it will be done post-operative. Okay, I don't do it pre-operatively. If you notice, कि हमने जो भी cancer किए पहले, we did PET scan to look for metastasis before surgery, like esophagus, stomach, colorectal, breast cancer. We did PET scan before surgery to look for metastasis. Here we are not doing it. Here we are doing this iodine scan after surgery. Okay, after surgery. This is serum TG. TG is thyroglobulin. It's a tumor marker of thyroid, right? So these are the two cancers which I can very easily treat, whether it is papillary or if it is follicular, easy to treat. The one which cannot be treated is anaplastic. Okay, anaplastic is very aggressive. It is seen in elderly. It is poorly differentiated. So typically after 60 years, it will be rapidly growing. Okay, so it grows very fast. It will quickly infiltrate all the adjacent organs. So it will infiltrate trachea very fast. It will infiltrate recurrent laryngeal nerves. It will infiltrate carotid artery. So fast, it will infiltrate everything. So by the time the person presents, he is already in a very advanced state. This tumor will never present at an early state. He is already in an advanced state. So very difficult to treat. How is this diagnosed? How do you diagnose it? How is this diagnosed? FNAC. FNAC. Mr. Nikhil? Nikhil wants to answer? Yeah. So this tumor is the only scenario where I will do a open biopsy. Okay. So I will do an open biopsy, and on biopsy, it will look like this. What you see here, this looks nothing like thyroid. Like see over here. यहाँ आपको at least यहाँ पे thyroid दिख रहा है. This part. This looks nothing like the thyroid follicles. You will see multinucleate cells. अभी thyroid में थोड़ी ये सब होना चाहिए. Multinucleate cells, abnormal looking cells, bizarre looking cells. Okay, so you see all these abnormal looking cells, and that tells you, okay, it is anaplastic. Problem is this cannot be treated. So the treatment for this is only palliation. You don't do total thyroidectomy because it is a very advanced tumor. So by the time it is diagnosed, most of the times you will not be able to remove it. So there is no treatment for it per se. ठीक है? बढ़िया. So these are the cancers that you need to know. Abhishek, there is nothing like simple biopsy. That simple biopsy does not mean anything. Okay, answer this. Female underwent total thyroidectomy. It showed papillary thyroid cancer. What will you do next? So this is simple. This is simple. This is going to be radioiodine scan. Okay, but please understand this is only done for papillary thyroid cancer and follicular thyroid cancer. Only for the original thyroid cancers. सिर्फ इसमें होगा, इसी में आपको मिलेगा थायरोग्लोबुलिन, इसी में आपको मिलेगा आयोडीन अपटेक, इसी में आप करेंगे ये चीजें. These things are only done for papillary and follicular. They are not done for medullary, definitely not done for anaplastic. Anaplastic, medullary वगैरह में ये सब नहीं करते because they are not going to be beneficial. Right? So only PTC, FTC will you do iodine scan. Only PTC, FTC you will do thyroglobulin, TG. Okay? Thyroglobulin लिखा है मैंने, फिर मत पूछना. So that completes our endocrine. This was the part that was left yesterday. Now we come to urology. You will get questions from urology, and 100% 2-3 questions will feature. And there are many small topics. So we will cover as many as possible. Right? So we start with kidney, ureter, bladder, urethra, prostate, testis. Okay, ऐसे करेंगे. So first we start with horseshoe kidney. Very easy. Horseshoe kidney is a congenital problem. So it's a congenital defect. Normally we have two kidneys. So you and me, we have two kidneys, and the kidneys are present in the flank. So you and I have kidneys over here like this. This is where our kidneys are, which will become the pelvis. Then you will get the ureter. Ureter will go down into the bladder. Normally, our kidneys are like this. In this case, okay, in this case, please understand when the kidneys are forming in the embryo, they are forming over here. This is where the kidneys form. And over time, they ascend upwards like this. तो ऊपर जाते हैं. Sometimes what happens, the lower poles of the kidneys by mistake get fused. By mistake. So they are so close to each other initially. Sometimes the lower poles touch each other and they get fused. And if they get fused, they will become one horseshoe kidney. So what you are getting here is a fusion of both kidneys. And where are they fusing? They are fusing at the lower poles. Okay, they are fusing at the lower poles. So because they are fused together, there is one problem. As they are going upwards, abhi fuse ho gaye, they want to go upwards. Normally, there is one artery behind the kidney, very important artery. That is the abdominal aorta. This abdominal aorta gives one artery, the lowest artery. Okay, it gives three arteries. The lowest one, inferior mesenteric artery, it goes like this. So this inferior mesenteric artery will come in the way. It will come in the way. So while the kidney is trying to go up, this inferior mesenteric artery will stop it from going. So what will happen is the kidney cannot go upwards. It cannot ascend because of inferior mesenteric artery. And this occurs at the level of L3, L4 or L4, L5. Where are kidneys normally? Normally kidney क्या होती है? At what vertebral level? कितनी ऊपर जाती है? Thorax में नहीं जाती है ना? What is our level of kidney normally? L1, L1, L2. So normally kidneys lie at जो यहाँ पर पहुँचती है, they lie at T12, L1. You know ना, there is one rib, 12th rib. जो 12th rib होती है, उसके just नीचे होती है kidney. So normally kidneys are at T12, L1. In this case, kidneys are much lower and fused. ठीक है, kidneys are functionally normal, बाकी कुछ problem नहीं है, सिर्फ ये problem है that they are fused together. So what? Is it a big deal? Is there any problem? Is there any complication? Kidneys are lower down, their poles are fused. So what? Big deal. Stones. क्यों stone भाई? UTI क्यों होना चाहिए? Uterine नहीं, not uterine, ureteric. So the problem is, ये जो ureter है ना, they have to go across the isthmus like this. ये जो connecting part है, this is called isthmus. That is the isthmus connecting the two kidneys. It's the bridge. So the ureters have to go across it. You can see ना कैसे जा रहे हैं. They have to go उसके ऊपर से. So sometimes the ureters can get blocked. Sometimes. Most of the times this doesn't happen. I'll write over here. Occasionally. हमेशा नहीं होता. So because the ureters can get blocked, the person can get urinary tract infections. So because of this, he can get urinary tract infection or renal infections. Or he can get stones because of urine getting infected again and again and again. बस इतना ही है. So how will the person present clinically? Most of the times, this is diagnosed incidentally. Just like gallstones, this will also be diagnosed incidentally. Sometimes patient can present with the complications. So how are you going to diagnose it? What is the diagnosis for horseshoe kidney? So most of the times it will be seen on imaging. And what imaging will you do? You will do USG, KUB. KUB means kidney, ureter, bladder. उसमें मिल जाता है most of the times. So USG KUB is good enough to diagnose horseshoe kidney. What is this image? ये क्या है? What are all these white things? What are all this white? ये क्या है? What is the imaging modality? This is CCT. CT ऐसा थोड़ी ना दिखता है भैया, ये कौन सा CT है? CT में ऐसे थोड़ी दिखता है हाइपरडेंस. नहीं, हाइपरडेंस नहीं है ये. This is called as IV, intravenous urogram, IVU or intravenous urogram. It's a type of X-ray. Okay, it is a type of X-ray. It's a contrast X-ray. Someone wrote correctly, contrast X-ray. Like how you have barium meal, barium swallow, same way you have IVU. So where is the contrast given? In barium meal you drink the contrast. How is the contrast going here? Contrast कौन कैसे पहुंचा यहाँ पर? पिया तो नहीं है पेशेंट ने, ऑब्वियसली. तो इसमें कैसे पहुंचा कॉन्ट्रास्ट? आईवी. ऑब्वियसली नाम में लिखा है ना आईवी. So contrast is given intravenously. This contrast, it's iodine contrast. It goes in the blood. From the bloodstream, it will go to the kidneys intravenously. Kidney will take the contrast, form it in urine, release it in urine. It will enter the pelvis. It will enter the cholysis. It will enter the ureters. It will reach the bladder. So I take X-rays one after another after giving the contrast, and I can see, oh, first contrast is here. After some time, contrast will enter the ureters. After some time, contrast will enter the bladder. So slowly, I take 4-5 X-rays at 5-5 minute intervals, and I can see the contrast going down. आई बात समझ में? So if I can see kidney like this white, if I can see bladder like this white, X-ray पे थोड़ी ना bladder दिखता है. You don't see kidney bladder. करा लो पेट का X-ray, देख लो, you will not see it. But if I can see kidney, if I can see bladder, I can see ureters, it means it's a contrast. Contrast normally will be intravenous. Okay. Now see what you see in this contrast X-ray. What you see here is kidneys should be higher up. They should be like this. Here the kidneys are lower down. And they are so close to each other. So on IVU, I see lower placed kidneys. They are much lower. They are much closer to each other. Sometimes I can also see that isthmus. इसमें नहीं दिख रहा, but sometimes I can also see the isthmus. And what I also see is the ureters go like this. They first go over here, and then they go laterally like this into the bladder. This appearance is called as flower vase ureter. Okay, this is called as flower vase ureter. Flower vase ureter means horseshoe kidney. Okay, don't say MCU. I just said that it is IVU. So why are you saying MCU? So don't create unnecessary confusion. इसमें इतने नहीं दिख रहे हैं क्योंकि ureters वैसे भी नहीं दिखते इतना easily, but you can see very faintly over here. जहाँ पे arrow marked है, all this is ureter. ये सब ureter है, इतने ही दिखते हैं. Classical नहीं दिखेंगे इससे ज़्यादा. But that's why I'm telling you, instead of looking for signs which are all imaginary, better to see signs like lower placed kidneys, closer kidneys. It's much easier to identify. Flower vase ureter, like you know, in achalasia, you were all saying bird beak. Also imaginary. How should you see achalasia? Smooth tapering. Same way, what should you see here? Closer kidneys, lower kidneys, horseshoe kidney. Simple. But yeah, you don't need it. आज के ज़माने में to diagnose it on USG. USG is enough. If you want, you can do CCT also. But most of the times, USG abdomen is enough. USG KOV. How do you treat this? What is the treatment of horseshoe kidney? Break the horseshoe. Nothing. So only treat the complications. Don't do any surgery for the horseshoe. Only treat the complications. So if he's having UTI, if he's having stones, only to be treated. Don't cut the isthmus. Okay, if there is an isthmus here, don't cut it. कुछ फायदा नहीं होगा. पहले के जमाने में करते थे, आज के जमाने में नहीं करेंगे. So currently the treatment is going to be only treat the complications, nothing else. Right? Okay, answer this. Very nice image. First tell me, what is the imaging modality? So this is how CT will look. How you guys were saying CT for that weird eye view. That's not CT. This is CT. This image was asked. Very nice, very easy image. If you can't understand the images, na, use some common sense. Try to identify what they are focusing on. So what you see here, this is the vertebra. Probably this is L3, L4, some vertebra this is. And you are seeing this structure here, just in front of vertebra. So you can see this will be probably IVC. This will be probably aorta. Most probably. ये दो tubular structures होते हैं just in front of vertebra. IVC, aorta. Right में IVC, left में aorta. And कायदे से your kidneys should be over here. But now you can see they are so near the vertebra. So close. And best thing, you can see the connecting isthmus. Isthmus भी दिख रहा है? और क्या चाहिए लाइफ में? इतना सब तो उन्होंने दे दिया आपको. So what you are seeing here is instead of having kidneys here, you are seeing kidneys here. And you can see that they are fused, joined in the middle, like handshake. So of course, this is going to be horseshoe kidney. Simple. Common sense will solve a lot of problems in your life. Okay. What view of CT this is? What is the view? Is it coronal? Is it sagittal? Is it axial? What cut is this of CT? कौन सा view है? Is it a coronal view? Is it a sagittal view? Is it an axial view? You are saying coronal. Absolutely wrong. This is called as axial view. When I cut the body and I look, that is axial. Coronal is from the front. If I see from the front, it would look a bit like how your X-rays look now. Something like this. That is coronal CT. Okay, this is axial cuts. These are called axial cuts. Okay, so just giving you some more extra information which will help you in your life, because I think in radiology you have only one session, so ma'am will not be able to cover everything. So hopefully if you are ready with some of these kind of things, hopefully she will feel Amrit sir ने कुछ तो अच्छा पढ़ाया, hopefully. So please मेरा थोड़ा नाम रखना. Okay, now come to another important disease called renal stones. So what do you see in renal stones? Or rather, why does someone get renal stones? Basically, you get renal stones due to problem in urine. Like how you got gallstones due to problem in bile. Whenever urine concentration changes, you will get stones. For example, if the urine has too little water, person is dehydrated. So one of the problems is too little water, dehydration. Too many salts, like too much of calcium, too much of oxalate, too much of cysteine, xanthine. So these chemicals, uric acid, if these chemicals are too many, you will get urinary stones. And the third reason for stones is urinary infections. So these are the three common reasons for getting stones. Right? There are many types of stones, but I'll tell you what are the important stones that you should know. The most common stone is the calcium oxalate. Okay, अगर आप में से किसी को renal stone हुआ होगा या ureteric stone, most of you would have gotten calcium oxalate. This is the most common type. Which one of these is calcium oxalate? How do the crystals look? So if I do a urine analysis, what is the appearance of the crystals of calcium oxalate? इसमें से कौन से हैं calcium oxalate? 1, 2. अरे उस पे लेटर लिखे हुए ना. लेटर लिखे हुए हैं ABCDEF. बाय द वे ये जो इमेज है ना, इट्स अ गूगल इमेज. ऑल एप्स विल हैव द सेम इमेज. सारे के सारे कोई भी ऐप खोल लो, उसमें रियल स्टोन की ये पिक्चर होगी. एग्जाम में ऑल्सो दे विल गिव द सेम इमेज, because there are very few good images showing all the stone ke crystals. So the crystals of calcium oxalate are either going to be dumbbell shaped. Dumbbell यानी ऐसे, that is this. इतना ही दिखता है dumbbell. Don't imagine actual gym वाला dumbbell. Or they will be ये वाले, image C, which are called as envelope shape. Okay, they will look like this, like an envelope. Right. So these are the common stones. Because they contain calcium, they are going to be seen on X-ray. They are usually radio opaque. So they will be seen on X-ray. X-ray पे दिख जाते हैं. Yeah. Spiky. Mona is dumb. Oh. To remember, dumbbell for calcium oxalate monohydrate. Stereotyping, body shaming, all together. है ना? ये ऐसी निमोनिक में ना जिंदगी बर्बाद हो जाती है. Come on, Nitya. Mona is dumb. Don't do that. The other type of stone that you get is called as triple phosphate. Also called as struvite. Also called as staghorn. It is basically triple phosphate because it contains calcium, magnesium, ammonium, phosphate. Okay, calcium, magnesium, ammonium, phosphate. That is why it is called triple phosphate. So, which of these is triple phosphate crystal? How will it look? The crystal of triple phosphate. How does it look? E. No, it's not E. It is this one, B. It is called coffin lid appearance. इसके लिए क्या निमोनिक है? बता दो मुझे. Struvite is dead. ऐसा कुछ है क्या? Triple phosphate is dead. Something like that. कृष्णा कुमार, कम से कम 5 बार you have written can't understand my handwriting. आप अपनी आंखें चेक करा लो. सच में 8 साल से पढ़ा रहा हूं मैं, वापस बोल रहा हूँ. आज तक किसी ने मुझे नहीं बोला कांट अंडरस्टैंड. चलो इट्स नॉट वेरी नीट, बट कांट अंडरस्टैंड तो मैं मान ही नहीं सकता. दैट इज इम्पॉसिबल. तो आप अपनी आंखें चेक करा लो कृष्णा. ओके, इसका क्या आंसर है? 3 बार हम कॉफिन में जाते हैं. I don't know any mnemonic for this. Let's not run behind mnemonics. So it is coffin lid. This is also going to be radio opaque because this contains calcium, magnesium. All of them are going to be radio opaque. So this is radio opaque and it is formed in infected urine. बस ये 2 स्टोन अपने को पता होने चाहिए. Staghorn is basically because ये जो स्टोन होती है ना, it will fill the entire pelvic alytial system. So when the stone forms, it will not be a chota sa stone, it will be a big stone and it will fill the entire pelvic alytial system like this. So the stone will look like this, like the horn of a stag. ऐसे ऐसे होगी ये stone की appearance if you remove it during surgery, right? That is why it is called staghorn. The crystals are going to be coffin lid. What is this? ये कौन सी stone की crystal है? Which one is this? Hexagonal. This is going to be cystine stone. I will give you one mnemonic for this. 6 sides in a hexagon, 6 letters in cystine. Okay, ये मेरी mnemonic है. If you hear it somewhere else, you know it's come from me. Okay, और किसी की नहीं है. So 6 letters, 6 sides to cystine. Very good. Someone wrote hard stone. Absolutely right. It's not very easy to break. Absolutely correct. ये कौन सी stone है? The image E. Which stone is this? uric acid. Yeah, this is uric acid. Why will you remember it as uric acid? 4 sides. It's rhomboid shape, so it is uric acid. 4 letters in uric, 4 sides in rhombus. So it is a rhomboid crystal, okay, of uric acid. This uric acid is not seen on X-ray. So you can write over here that uric acid crystals, which are going to be a rhomboid, but these stones are not seen on X-ray. So they are not seen because they are radiolucent. ठीक है, बस मेन यही है. Now coming to how will you manage renal stones. So if a person comes with colicky pain and you think he has renal stones, what is the first test you will do? Patient comes with colicky pain, hematuria. What is the first test you will do? आपने कराया होगा ना? I am sure some of you would have suffered from renal stones. I am sure. So how will you investigate patient with renal stones? Remember in urology, like now you've done enough surgical topics with me. In GIT, endoscopy. In lower GIT, stool test followed by colonoscopy. In obstruction, X-ray followed by CT. In breast, triple assessment. In thyroid, triple assessment. So अभी आपको सब बैठ गया. In hepatobiliary, LFT, USG. वैसे ही करना है. एकदम same principle है. Anything in urology, first you will do urine test, urine routine microscope. Okay, it may show you blood in urine, which is called as hematuria. How many RBCs should be present to label someone as hematuria? कितने होने चाहिए RBCs? Because if we do our urine test, we may be having 1 or 2 RBCs. Very good. They should be more than 3 to 5 per high power field. अलग-अलग लैब में अलग-अलग रेंज होती है, but approximately more than 3 to 5 RBCs for high power field. If you see hematuria and you are suspecting stones, you are going to do this test. What is this test? ये क्या किया आपने? Routine microscopy, urine routine microscopy, like you did stool routine. What is this test? Is it X-ray or is it intravenous? Is it X-ray or intravenous? So this is a X-ray, but it is not an X-ray of the abdomen. It's a little lower down. You can see this hip bone पूरा का पूरा आपको hip दिख रहा है. Abdomen X-rays में इतना नीचे तक थोड़ी जाते हैं. Abdomen X-rays में you take chest, diaphragm, abdomen, maybe little pelvis. यहाँ तो पूरे pelvis तक गए हो, यहाँ तक गए हो. So it's a much lower taken X-ray. So this X-ray is called X-ray KUB. Okay, why is it not IVU? Why it is not IVU or IVP? KUB stands for kidney ureter, kidney ureter bladder. So yeah, why is it not IVU? I am happy some of you are giving the good answers. In an IVU, bladder will have contrast. So bladder will be white. Kidneys may be seen completely as white. Ureter, pelvis on both sides will be seen as white. Like you saw over here. इसमें था ना? See, white kidneys. See, white bladder. If you see contrast in bladder, that means somewhere contrast has been given. White bladder means कहीं तो contrast दिया, या intravenously दिया, or maybe it can be given from below also. Right? So, what do you see in this KUB? Is it normal KUB? No. So, what do you see here? Very important. This is a radio opacity. Very big radio opacity over here. You should not be seeing any radio opacity white thing in the area of kidney. This is a Staghorn calculus, this one that you see. So you can see radio opaque stones sometimes. In this case, you are seeing it. Here also, if you notice, stones are forming. थोड़ा थोड़ा दिख रहा है आपको stone formation. Here also, if you notice, maybe this is also a stone in the bladder. इधर से टूट के गया होगा नीचे, maybe. So you are seeing radio opacities. What is the investigation of choice for renal stones? So investigation of choice for renal stones, very important. It's going to be plain CT, KUV. Okay, plain CT, KUV. अभी तक हमने प्लेन सीटी एक ही जगह पे यूज किया है. Anybody remembers where else did we do plain CT? नॉन कॉन्ट्रास्ट कहाँ पे किया है? आज स्टोन में किया है, कहीं और कल किया था प्लेन CT. Yeah, excellent. Head injury. Head injury also we did plain CT. Normally we do contrast CT for abdomen, for chest. Normally contrast. So I always told you CCT, CCT, CCT. But head injury, where I want to see bleeding, plain CT. Urology, where I only want to see stones, plain CT. USG will not pick up every stone. If the person is obese, then ultrasound will not reach the stones, unfortunately. Okay, so investigation of choice here is not a USG. You may do it, it may pick up if you are a thin person, but CT is the best investigation. Last part is treatment. So how do you treat stones? If the person comes with emergency colic, emergency में आया with colic, you will give him NSAID. On the other hand, once the colic is gone, you did the imaging, you saw एक दो stone है, बड़े है. So what are you going to do? So the treatment, you can do non-surgical treatment. Non-surgical means wait for it to resolve, wait for it to pass. Which stones can you wait for it to pass? Did it pass naturally? ये कौन से stone में करेंगे? So your ureter, bladder, urethra will allow stones less than 5 millimeters. If the stone is 5 millimeter or more, it will not pass. Ureter में वो फंस जाएगा. Okay, so stones 5 millimeters or more have to be removed by some intervention. What intervention do you have? You can do minimally invasive procedures. ये मेरे image में क्या है? What is this image? Minimally invasive. What image is this? औरत लेटी हुई है, कोई मशीन है अजीब सी. Looks like an ultrasound machine. Excellent. So in minimally invasive, the best thing you can do is what is called as ESWL. That is this ESWL. ESWL is called as extracorporeal shockwave lithotripsy. What does the word lithotripsy mean? ये word क्या है? Lithotripsy. What does it mean? Lithotripsy. बताइए. Excellent, excellent. Litho means stone, like polylithiasis, gallbladder stone. So lith means stone, tripsy means torn. You break it. So this machine, what it does, there is no surgery here. It will throw ultrasonic shock waves. So first you see where the stone is, and once you see the stone on ultrasound, then this machine will focus the energy on the stone directly. It's all going from outside, ना? कुछ उसमें surgery नहीं है. It's non-surgical. So shock waves will go and break the stone. So you send shock waves to break the stone. So stone will break into small pieces, which will be less than 4 millimeters, 1 millimeter, 2 millimeter, and then the stones will go into the ureter, bladder, and he will piss them out. Which stones can't be broken by? What is the contraindication for ESWL? Can I do it for every damn stone? When can I not do ESWL? Contraindication. So first and foremost, you cannot do it if the patient is having pregnancy, because you may end up breaking the fetal skull also. If the person has bleeding problems, and apart from that, it will work only for stones up to 20 millimeters. So if the stone is more than 20 millimeters, or it's a hard stone will not break, like cystine. Or if it's a very big stone, like a staghorn stone, or if the stone is in the lower calyx. Okay, don't worry about lower calyx for now, but if the stone is in the lower calyx or very big stone, very hard stone, those stones cannot be broken. They will get stuck. Okay, so if this is the scenario where the stone can't be broken, then what do? What is the next step? ESWL is not possible. What should I do? Patient is pregnant, or stone is very big, stone is very hard. In that case, the next step is going to be this procedure. This is also minimally invasive, but it's a proper surgery. This is called as PCNL. PCNL stands for percutaneous nephrolithotomy. What does nephrolithotomy mean? What does nephrolithotomy mean? Litho means stone. Otomy means, yeah, otomy means you cut and remove. So understand, here I am not just breaking, I am breaking and taking it out. So however big the stone is, wherever it is located, this is done in OT, this is done by a urologist. Yeah, this is not done by a radiologist, this is done by a surgeon. Surgeon माने urology surgeon, stone surgeon, मैं भी नहीं कर सकता है. So this is done in anesthesia in OT, where you pass a nephroscope like this. So from the skin percutaneously, you pass a nephroscope and you manually break the stone and take it out. So however big the stone is, it can be done. Is there any place where I can't do PCNL? Any contraindication for PCNL? It's not non-surgical. I said minimally surgical. मैंने non-surgical कहाँ लिखा है? इसका मतलब है minimally invasive. So the only place where I can't do it is if the woman is pregnant. Pregnancy is the main contraindication. बाकी कुछ भी contraindication नहीं है. तो 100 बात की एक बात, if they give you a simple case, 8 mm, 10 mm stone, ESWL. They give you a complicated case, patient is having some problem, patient is having obesity, stone is very big, hard stone, staghorn stone, complicated stone, PCNL. Okay, so keep it simple. Anything under the sun which you can't understand, आपको अजीब लग रहा है, इन्होंने कोई सिनारियो दिया है, go for PCNL. Okay, so this is the main scenario. Bleeding is a complication, it's not a contraindication. And if nothing works, of course, you have surgery to remove the stone. But surgery is rarely required. You can do open surgery, which is called as pyelolithotomy. But this is rarely required. And how do you treat stones in the ureter? ये तो kidney के stone है. If the stone is in the ureter, what will you do? Ureteric stone. Kidney से नीचे चला गया ureter में, लेकिन आगे नहीं जा रहा, ureter में जाके फंस गए, तो क्या करोगे? No, Dormia basket is not the treatment. Force, अरे बड़ी स्टोन है, नहीं पास हो रही है, ureter में आके फंस गई है. So the treatment for ureteric stone is very simple. It is called as ureterorhinoscopy. Okay, ureterorhinoscopy, simple, easy. Stone in ureter, ureterorhinoscopy. Stone in kidney, small stone can pass 5 mm to 20 mm, soft stone, ESWL, hard stone, big stone, complicated patient, PCNL. Someone is asking, what do you do in pregnancy? There is one endoscopic technique, but I don't want to bring it over here. It will unnecessarily complicate it. So for us, let us restrict ourselves to this. If patient is pregnant, there is some other technique. It's an endoscopic technique. पर उतना आगे मत जाओ, इतना कर लो. इसमें से क्वेश्चन आया तो बहुत बड़ी बात है if you are able to answer it, because even PGs are not able to answer it. So इतना बस है. आपको चाहिए आप मुझे बाद में टेलीग्राम पे या इंस्टाग्राम पे पूछ लो, मैं बता दूंगा. Yeah, answer this. So patient comes with pain in abdomen. The following image is obtained. And what is the management option for this? ESWL. Why ESWL? Why are you saying ESWL? Where is the stone? Or how do you make out where the stone is? So let's simplify it. This is the sacrum. Okay, ये sacrum होती है, यहाँ पे bladder होती है कहीं. ये कौन सी vertebra है? L5. This will be L4. This will be L3. This will be L2. This will be L1. Where are the kidneys? T12, L1 over here. Kidneys will be over here. T12, L1, L2. Your stone is over here near L4. So where is the stone? In left ureter. Absolutely right. So this stone is in the left ureter. So the treatment will be ureterorhinoscopic. Okay. Treatment will be ureterorhinoscopic removal. थोड़ी anatomy अगर आ गई ना आपको, थोड़ी सी, ऐसे क्वेश्चन तो आप आंख बंद करके सॉल्व करोगे. थोड़ी बेसिक anatomy चाहिए बस. Okay. Any question on renal stone you should be able to answer. No problem anymore. Some are very straightforward one-liners. Some are little clinically oriented, the kind that they are asking now. Like they ask this, it's a PYQ. But yeah, थोड़ी basic understanding चाहिए. You will be able to answer these kind of questions. You will never make a mistake. Okay. Now coming to topics which we are very comfortable with in our life. ये small नहीं है ना. अगर small होता तो already pass हो चुका होता. Small stone कभी नहीं देंगे image पे. अगर स्मॉल होता तो पास हो गया होता ना, तो अटका क्यों हुआ वहां पे, एक्सरे में क्यों दिख रहा. नाउ कम टू टॉपिक्स व्हिच वी आर वेरी कंफर्टेबल विद. Cancers. Any cancer question you should be like, yes, I will get it, because we know a system in place. We know there will be those same kind of risk factors, same kind of presentations, same kind of staging, metastasis, then you will treat it early, advanced, metastatic. वही करना है. तो पहले करेंगे RCC, very easy. सारे यूरिनरी कैंसर कर लेंगे, पट 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 पट, कोई तकलीफ नहीं होगी. फर्स्ट वी स्टार्ट विद RCC. सो RCC is also a bad cancer. It is also going to be seen in elderly, smoker, man with obesity. वही सेम रिस्क फैक्टर्स, वही जो मैं आपको GIT में पूरे 2 सेशन टिका रहा था, यहाँ भी वही है. So elderly, smoker, man with obesity. Obesity यहाँ भी है. Renal cancer is of many types pathologically. The most common type is called the clear cell cancer. Clear cell variant. This is the most common type. It is associated with a disease which is called as VHL syndrome. Von Hippel-Lindau syndrome. शायद आपने सुना होगा मेडिसिन में या पीडियाट्रिक्स में पढ़ लेना. Von Hippel-Lindau syndrome में clear cell cancer होती है. The other type is called papillary renal cancer. Like you had a papillary thyroid cancer, you have papillary renal cancer. What did you see in papillary thyroid cancer? On biopsy or on excision biopsy? क्या दिख रहा था? Samoma. इसमें भी दिखेगा samoma. Here also you will see samoma. This cancer is seen in people who are on hemodialysis. Then there is a type called medullary. This is the type which is seen in children who are suffering from sickle cell trait. Not sickle cell anemia, sickle cell trait. तो जिनमें sickle cell trait होती है, उनमें medullary type की cancer होती है. And there is a fourth type which is called chromophobe type. Chromophobe variant. This variant has a good prognosis. Why I'm telling you this is because all these are one-liner MCQs. तो ये आपको easily आ जाने चाहिए. Chromophobe type will have the good prognosis. How will person with RCC present? How will a person with RCC present? He will be elderly smoker male. What will he come with? Normally, tumor in the kidney. So most diseases in urinary tract will present with same kind of features. So he will be elderly and he will present with gross hematuria. Gross means it will be profuse. क्योंकि क्या होता है ना, किडनी में जो ट्यूमर होती है, as it will grow, as the tumor will grow, it will start bleeding. तो नॉर्मली ऐसे ट्यूमर होती है किडनी अपर पोल पे. थोड़ी slowly tumor will start bleeding, and when it bleeds, the blood will go in the pelvis. Then it will go in the ureter, bladder. So when he passes urine, he will say, बहुत dark urine है. It is having blood clots. Any patient elderly with blood clots in urine, you will think of RCC. Okay, there is one more differential for this. I will tell you when we get there. But elderly patient with blood clots in urine, it is going to be RCC. Okay. Sometimes you may feel the lump. So you may feel lump in flank. Sometimes. And you may get flank pain. But flank pain is very late. Okay. This is the triad of RCC. Hematuria, lump, pain. It is called too late triad because these things happen very late. It is called too late triad. जैसे आप लोग कभी एग्जाम में होते हो ना, ये पढ़ने को टाइम नहीं मिला, लेट हो गए, अफसोस. This is also अफसोस. So if patient gets these three things ना, hematuria, lump, pain, too late, अफसोस. Because by the time he gets these things, tumor has spread everywhere. Where does the tumor spread? What is the spread of the tumor? Where all can it spread? It can spread aspas, dur bhi, and cause many problems. Liver, no. Liver is for GIT. GI organs, esophagus, stomach, colon, rectum, they go to liver. This will not go to liver. This will spread. One is it can spread directly. So directly it will go to the gland on top, adrenal gland. It can go into renal vein. It can even go into IVC. Okay, so renal vein, yeah, IVC mein, it can go directly. That is not called as M1. That is not metastasis. That is direct spread. You can get lymph node metastasis. You can get hematogenous metastasis. Most commonly, to lung. And that appearance, it came in FMG, cannonball metastasis. This came in abhi wala FMG. Easy. X-ray diya tha. What is this appearance? It was cannonball metastasis. Right? So, ऐसे spread होती है, and there is something special that can happen, which is called as paraneoplastic syndromes. The person can present with paraneoplastic syndromic features. Like he can have raised ESR. This is the most common type. He can have hypercalcemia. He can have liver dysfunction or liver derangement. This is not directly because of the tumor. It is because the tumor produces some hormones, some enzymes, which cause these changes. What is liver dysfunction called? In RCC, it has a name. Anybody knows? Liver failure or liver dysfunction in patient with RCC. What is this called? This is called as Stauffer syndrome. No, not hepatorenal. Not hepatorenal. It's called Stauffer syndrome. Okay. So the person will get jaundice, he will get deranged LFTs, even though he has RCC. It's because of some enzymes, some interleukins. Anyways, how will you investigate? Person comes with gross hematuria. What will you do first? cross hematuria, elderly, yeah, interleukin 6. Very good. I'm so happy. The first step is going to be urine routine microscopy. Don't jump to CT. You'll do urine routine. You will see blood. And sometimes you can also see cancer cells. If you do a urine cytology, you may see cancer cells also. But that will be seen on cytology. What is the investigation of choice? How will you diagnose it? Diagnostic test for RCC. CT with biopsy, IVU, X-ray KUB, USG, सब आ गए. Okay, so do you do biopsy or no? Or just CT? So remember, solid organ tumors, RCC, liver tumors, they don't require biopsy. So investigation of choice is going to be CT. No biopsy. Biopsy is not needed. These tumors are going to be diagnosed on imaging. Okay, biopsy की कोई जरूरत नहीं. What will you do next? Next step, after you have diagnosed, okay, CT पे दिख गया कि it is a renal cell carcinoma. What will you do next? Staging, excellent, excellent. How will you stage? Why no biopsy? Because you don't need biopsy to diagnose it. जरूरत नहीं है, CT पे समझ में आ जाएगा. So for staging, you will do two things. For local staging and to look for IVC invasion, because the tumor can invade the IVC, you will do MRI. It is called as MRI venogram. And for distant metastasis, you will do PET scan. So what I'm trying to tell you is, all the cancers that we have studied, now you understood the concept. The concept is going to be that you have to first confirm where the tumor is, how big it is, which type it is. Then you want to stage where it has spread region, where it has spread distant. बस सारे कैंसर ऐसे ही करने. Kidney function test is not for diagnosis, it is for preoperative fitness. So kidney function test will not tell me there is an RCC, but it will be done. I will do kidney function, renal function, liver function, all tests I will do, but those are for fitness for surgery, not for diagnosis. जैसे अगर आपको हर्निया सर्जरी करानी है तो भी आप किडनी फंक्शन टेस्ट करते हो, वो हर्निया के लिए नहीं ना, वो सर्जरी के लिए. Based on this, you will know the TNM staging. Now in urology, we have an even simpler formula. For every stage, you have a fixed treatment. So you only need to know the TNM stage. If you know the TNM stage of the tumor, for every stage there is a parallel treatment. We will do this for kidney, we will do this for bladder, prostate, testes. सब ऐसे ही, एकदम simple. For the cancer का stage, you should know the treatment. I have never heard of PET MRI. Okay, I only know of PET CT. PET MRI आपने शायद उसका invention किया होगा, मैंने तो नहीं सुना. So the staging is going to be TNM. What does T stand for? T stands for what? In RCC. इसमें बोलना नहीं डेप्थ है. There is no mucosa, submucosa. Tumor what? कल भी यही बोल रहे थे. It is tumor size or maximum diameter. Okay, like breast. Depth is only for hollow organ tumors, where there is a depth possible. For solid organ tumors, RCC, breast tumor, it's only size. Okay, it is not depth. There is no depth affected here. So T1 has T1A, T1B. T1A, tumor size up to 4 centimeters. T1B, tumor size 4 to 7 centimeters. Then you have T2. T2 is going to be size more than 7 centimeters. Then you have T3. T3 is going to be tumor invading any size but invading renal vein or invading IVC. So I told you renal vein and IVC, this is not metastasis. This is going to be direct spread. And T4 is going to be breach of Gerota's fascia. ओके, सो यू नीड टू नो दीज नंबर्स. ये यूरो के जो कैंसर्स है ना, उसके आपको नंबर्स पता होने चाहिए, नंबर्स या टाइप्स एटलीस्ट अप्रोक्सीमेटली. व्हाट डू यू थिंक इज बेटर apart from surgery for RCC? Will you give chemotherapy or will you give radiotherapy? GI cancers will give chemotherapy. RCC में क्या देंगे, कीमो देंगे या रेडियो देंगे? रेडियो. ब्रीच, ब्रीच रे, ब्रीच इंग्लिश वर्ड है, ब्रीच्ड. जेरोटा is breached. So the problem with RCC is, unfortunately, it is chemo and radio resistant. So I am left, unfortunately, with only one thing, that is going to be surgery. So I cannot give at neoadjuvant chemo, make it small. ऐसा वो option ही नहीं है. Chemo radio है ही नहीं इसमें. So unfortunately, I can only do surgery. So if it is T1A, the surgery that I do is called as partial nephrectomy. Okay, it is called as partial nephrectomy. Partial means tumor with some margin. पूरी किडनी निकालने की जरूरत नहीं है. In T4, in T1B, I can do partial nephrectomy if possible. Partial if possible. If not possible, I will do radical nephrectomy. Radical means पूरी किडनी निकालनी है और उसके lymph nodes भी निकालनी है. That is called as radical nephrectomy. You know the meaning of the word radical. Whenever you hear radical, निकाल दो. For T2 and T3, you can only do radical nephrectomy. So even if the tumor is going in the IVC, you can still remove the tumor. Okay, that is called radical nephrectomy. If the Gerota's fascia is breached, then you will do palliation. And in palliation, you can give what Shama has written. You will give immunotherapy. उसने कोई नाम लिखा है ना, P से कोई गंदा सा नाम है. That is for palliation. That is not for cure. Okay, it will not treat the RCC. It's not a adjuvant. Pembrolizumab. We have used sunitinib. आपने शायद ये नाम सुना होगा, sunitinib. So sunitinib is for palliation. It's not for cure. Nephrologist does not do surgery, my dear. Nephrologist only manages renal function. Yeah. So unfortunately, there is no chemotherapy here. You can only give palliation. For T1, T2, T3, you can do surgery. Where possible, you will do partial nephrectomy because you can save some kidney. And not possible, radical nephrectomy, जिसमें आप lymph node, पूरी kidney सब निकालो. Okay. So simple step-by-step, stage-wise treatment of RCC. Okay, answer this. A 65-year-old male presents with a mass. So elderly male, the mass in the lumbar region. He was found to have a 8 by 5 by 3 centimeter mass confined to the kidney. Diagnosed as RCC. What will you do? What is the treatment? So in RCC, please straight away remove chemoradiation. Resistant. ये तो कहीं भी मत देना. 8 by 5 means it's a T2 tumor more than 7 centimeters. Best answer will be radical. Okay, best answer will be radical. Yeah. Okay. Now come to urinary bladder. Same. It's like RCC only. Means in presentation it is the same. This also is going to be a bad cancer. This, however, just like you have esophagus, stomach, bladder is also a hollow organ. You know? So this bladder also has mucosa, submucosa, muscularis. ऐसे होते हैं इसमें. If I go from in to out in the bladder, I have the epithelium or the mucosa. What type of epithelium is this? In the bladder, what is the name of the epithelium? Is it squamous? No, it's not squamous. It is transitional. Excellent. So I have epithelium then I have submucosa, then I have the muscle layer. What is the name of the muscle? कौन सी मसल होती है ब्लैडर में? एकदम मोटी सी मसल होती है which has three layers of muscles. Excellent. That is called detrusor muscle, powerful muscle. What lies outside the bladder? What is this last layer? The wall of the bladder. Is it serosa or something else? Is it serosa? Adventitia. Adventitia. Absolutely right. इसमें serosa नहीं होती है bladder में. This is adventitia. So from in to out, there is transitional epithelium, some mucosa, muscularis, adventitia. I am telling you this for a reason. Huh? There is a reason why I am telling you this. The cancer will come from the epithelium. So most of the times, the most common type of cancer is the transitional cell carcinoma. Most people get this. It's not squamous cell, it's not adeno, it is transitional cell C. Why does someone get it? Risk factor same. Elderly, smoker, male. तो देखो सब जगह हमने यही टिकाया. Elderly, smoker, male. I am telling you, if you are listening to the cancers that we have done, when you are going to study cancer, even if you study after 2-3 months, ये words ना आपको चमकेंगे. हाँ 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 हाँ, elderly smoker male, हाँ, एकदम you will get a flashback, which I don't feel you will get in too many subjects. What students often tell me is, एक बार मैंने subject पढ़ लिया, when I move on to the next subject, the earlier subject is gone, forgotten. So from surgery you will go to radio, derma, whatever other subjects, you will feel सब भूल रहे हैं. ये चीजें नहीं भूलोगे. Because the moment you will put your eyes on these kind of words, the keywords, or you will get full flashback. It will not be a clean slate, which you may feel in other subjects. For sure, you will not feel here. So, elderly smoker male, important risk factor, and there are some occupational exposures. So, there are some occupational risk factors. So, people working in textile factories, people working in petrochemical factories, people working in dye, battery, ये वाले जो फैक्ट्री में वर्कर्स होते हैं ना, they get exposed to some chemical carcinogens. Why do these carcinogens cause bladder cancer only? So if I work in textile factory and I have contact with all these dyes, chemicals, उसका skin cancer होना चाहिए ना उससे. Bladder cancer क्यों? If they enter my body because I have inhaled the fumes or because I have had contact with the things, ब्लैडर का क्या संबंध है? मैं ब्लैडर में थोड़ी डाल रहा हूँ कोई भी डाई को. हमारे stored in the bladder. How? Stored माने? So all these contrasts, all these dyes that I have exposure to, if they enter my blood, they are going to be eliminated in my urine. So urine will have these chemicals. The problem is kidney does not store urine. The kidney will throw the urine into the ureter. Ureter will throw it into the bladder. Bladder will keep the urine for some time, every few hours. So this chemical urine will keep hitting on your bladder every day, all the time. That's why you get bladder cancer. You should be getting renal cancer also, but you don't get because kidney will not store it. Kidney will push it. So chemical comes, push. Ureter, chemical comes, push. Bladder, innocent bladder, saves it. Saves it for what? To get bladder cancer. Okay, that is the message. I don't want you to memorize these things. है ना? Don't memorize everything. कुछ कुछ चीजें तो फंडामेंटली समझ के रखो तो आगे काम आए. वरना मेमोराइज करना है तो पूरी एमबीबीएस थोड़ी मेमोराइज करोगे. That's why you get these tumors. Now, how will the person with bladder tumor present clinically? He will be elderly male, elderly smoker male. What typical presentation will he have? What typical presentation will he have? PGL bladder. I don't know what that means. So typically, he will also have a gross hematuria because the tumor in the bladder will bleed. So any elderly smoker male with gross hematuria, you have only two differentials. One is RCC, other is bladder tumor. Okay, are we clear? Other will be bladder tumor. One of these two will be. So he can come with this. He can come with metastasis. Where does the bladder tumor metastasize? Normally, where does it go? Normally, locally. Yeah, where will it go locally? So locally, it can go from the bladder to the uterus if it is a female. Rectum if it's a male. It can enter the ureters and so on and so forth. It can go to lymph nodes. It can go hematogenously. Where will it go hematogenously? More commonly to the bones, followed by lungs. इसमें liver पे नहीं जाएगा. Urinary cancers don't go to liver. They go to bones, they go to brain or to lumbar vertebra. Because lumbar vertebra bladder के पीछे ही है ना, lumbosacral vertebra. So it will go to lumbar vertebra, close by. Right. So this is how it will spread. How will you investigate? Patient comes with gross hematuria. What will you do first? Gross hematuria, excellent, very good. I am happy. First, you will do urine, routine microscopy. You may see blood. Is there any tumor marker that you see in the urine? If you are suspecting bladder cancer, any tumor marker, very good. शायद आप notes पढ़ के बता रहे हो. It's called NMP22. It's a tumor marker. What is the investigation of choice for bladder tumors? How will you confirm your diagnosis? IOC. It is just like GIT. It's a hollow organ. So the investigation of choice is going to be cystoscopy with biopsy. What is the other name of cystoscopy with biopsy? What is it also called? Other name for cystoscopic biopsy for bladder tumors. It has another name, short name, 4-5 letters. No, radical cystectomy is the treatment. Cystoscopic biopsy means cystoscopy करके सिर्फ वो tumor निकालना है. What is it called? Yeah, excellent, Ketamine. Excellent answer. It is also called as TURBT. Okay, this BT is not the BT that you get in the class. This BT is bladder tumor. TUR is transurethral resection. Like you have transurethral resection of prostate, TURP. You have transurethral resection of bladder tumor. That is TURBT, not the BT that you keep giving me, right? So this is going to be the diagnostic test. What will you do after this? After TURBT for bladder tumor, next step, stage. How will you stage? Excellent. जिसने भी लिखा है local stage, बढ़िया लिखा है. You will do MRI pelvis. Okay. So rectal cancer, bladder tumors, uterine cancers, cervical cancers, CA prostate, all MRI. Okay. सारे pelvic organs MRI. Distant metastasis, of course, it's going to be PET scan. ठीक है. So easy. Last part, staging and treatment. ये तो बहुत आसान है, बहुत ही आसान है, आपके लिए आसान है. Here also you will have T1, T2, T3, T4, and there is a special one which is just before T1. It is called as TA. अगर याद रहा तो ठीक है, नहीं याद रहा तो कोई problem. What is T here, by the way? What does T stand for? Don't say tumor. Tumor के आगे का word बोलना. I am not interested in hearing T for tumor. Tumor what? Tumor depth. Yeah, tumor depth. Depth. So when the tumor will arise over here, what I am interested in, how deep is it spreading? So you look for tumor depth. So T1, tumor invading mucosa, submucosa. T2, tumor invading muscularis. T3, tumor invading adventitia. Because this has adventitia, there is no serosa. T4, tumor invading adjacent organs. ऐसा TNM staging कहाँ पढ़ा है हमने? कौन से दूसरे organ में same T stages, same to same, which other organ? At the same T stage. Esophagus, excellent. So bladder and esophagus have the same T stage. So easy. Same like esophagus. Esophagus and bladder have the same. Stomach, colon, rectum have the same T stage because they have serosa. आई बात समझ में? Not so hard. There is one TA. TA is invading mucosa, but not lamina propria. If you can remember it, fine. इतना important नहीं है. Not invading lamina propria. Okay, that is TA. याद रहा तो ठीक है, नहीं याद रहा तो कोई प्रॉब्लम नहीं. Right. So this is the T stage. Now how are you going to treat each stage? It's very simple. खाली दो लाइन बनानी है आपको. One is between T1 T2. Other is between T3 T4. Just make two lines. These tumors are early tumors, what we call as early cancers. For early cancers here, the treatment is going to be what you've already done, cystoscopic removal or TURBT. And after that, you will give an adjuvant chemotherapy. But this chemotherapy is not intravenous, it's not tablet. This chemotherapy is given directly in the bladder. That is called as intravesical chemotherapy. So the advantage is this intravesical chemotherapy. You put a Foley's catheter into the bladder. From the Foley's catheter, you inject some chemotherapeutic drugs like mitomycin. Or there is a, you use it as a vaccine, but you can use it for chemotherapy, BCG. So you can give these drugs into the bladder, let it stay in the bladder, and let it have a direct effect in the bladder wall. So it is an intravesical chemotherapy. ये और कोई कैंसर में हमने नहीं यूज किया. Because other cancers like GI cancers, you gave cisplatin, Folfox, Folfiri. So those are all tablets and IV. This is direct, no toxicity. But it can only be done early cancers, only mucosa, submucosa. If the tumor has gone into muscularis, then this contact chemotherapy will not work. So here what you are going to give, T2, T3, T3, you will do radical cystectomy. So you have to do surgery, radical cystectomy, followed by adjuvant chemotherapy. Bus. And here for tumor invading adjacent organs, you will do palliation. ठीक है, आई बात समझ में? सिंपल हो गया, ऐसा ही करना है. क्वेश्चन क्या पूछेंगे आपको? Either it will be this stage or it will be this stage, and they will ask you next step. One of the options will be intravesical chemotherapy. One of the options will be radical cystectomy. इसी पे क्वेश्चन बनेगा. Okay, इसी पे क्वेश्चन बनेगा. Ileal conduit is something that you will do once you remove the bladder. It's a reconstruction. अगर bladder निकाल दिया तो patient urine कैसे करेगा? For that you will do ileal conduit. But वो इतना जरूरी नहीं है. Means you don't need to know much about it. Ileal conduit करेंगे. बताओ इसका आंसर. Answer this. So, elderly, smoker, man, painless hematuria. He has a bladder cancer up to muscle layer, which means it is going to be T2. What will be the treatment of choice? Please don't do intravesical. This is only for TA or T1. Intravesical BCG. Systemic chemotherapy can be given later. Treatment of choice will be radical cystectomy. Okay, so treatment of choice, simple, radical cystectomy. So there are two kinds of traumas that you need to know in urology. First one is bladder, and then after bladder, we'll study urethra. Nowadays, they are asking questions on these very often. And confusion is perpetual, but don't worry, we will do it in a very simplified way so that any question on bladder rupture or urethral rupture, you should not make any mistake. Okay, जरा भी mistake नहीं होगी, एकदम simple है. You only need to understand the anatomy of bladder and urethra. Then rupture will become a cakewalk. So first understand where the bladder lies, when will it rupture, and what will be seen. So if you see from the side, the bladder looks like this. Okay, this is the bladder from the side. And I am talking about male bladder. Just in front of the bladder will be the pubic symphysis. Over here, the bladder will become the urethra. Like this. For now, I am only showing proximal urethra. So you have the prostate gland over here. And then you have a muscle over here below the prostate gland, which supports the urethra. Behind the bladder here is the rectum. Okay, and the rectum will become the anal canal over here. Right, behind the rectum is the sacrum, which I am not showing. What is this muscle that is supporting the bladder, neck, the prostate, the rectum? What is this? Yeah, this is levator ani. So this muscle levator ani will go forwards towards the pubis like this. ठीक है, यहाँ तक सब ठीक है. Here will be the abdominal wall, and the last layer of the abdomen is the parietal peritoneum. This parietal peritoneum will go on top of the bladder like this. This is the peritoneum, and then it goes in front of the rectum like this. Here on top will be the intestines. They will be on top over here. So bladder has peritoneum only here at the fundus. ठीक है, इतना ही समझना है. This is the most important part that you need to know. So my bladder, abdominal cavity on top, pubis in front, prostate and levator ani below, rectum behind. This is what you need to know in context of bladder. When will the bladder get injured? Okay, what will cause the bladder to rupture? Two things should happen for the bladder to rupture. First is you have to get a trauma in this area. Means lower abdomen or pubis. So there should be injury to lower abdomen, or there should be injury to pubis. Obviously, यहाँ force होगी तो ही bladder फूटेगा. Second thing is, for it to rupture, it should be filled, or it should be inflated or distended at the time of injury. So when the trauma happens, the bladder should be full. Obviously, agar balloon hai, when you fill it with water and then you will throw it, it will burst. A balloon which has no water in it or air in it is never going to burst. Same way, bladder is like a balloon. So when it has urine and someone hits it, it will tear. So this is the prerequisite. Now, how does it tear is what you need to know. It can tear in two ways. The first way is if the injury is to the lower abdomen. So injury is somewhere here, lower abdomen. This will go and the pressure will hit this roof of the bladder, the fundus. This will tear. And the peritoneum on top will also tear. So when the injury happens like this, injury to lower abdomen, and there is a tear of fundus of bladder with the peritoneum, तो उसके ऊपर की peritoneum भी फूट जाएगी. So what will happen is whatever urine was there inside the bladder, it will start going out from here towards the intestines, towards the mesentery. Intra-abdominal cavity में urine will start leaking. This is called as intraperitoneal bladder rupture. Okay, this is intraperitoneal bladder rupture. What will this lead to? If the urine is leaking into the peritoneal cavity, what will happen to the patient? Eventually, yeah, he will have chemical peritonitis. So this person will present with chemical peritonitis. Right. So what will I find when I examine this patient? So when the patient comes to emergency, what will I find? The first thing is, the first history he will give is there is history of injury to lower abdomen. And second thing is he will say, he will not know whether bladder was distended or not, but what will he say? He will say, since the injury, I have not been able to pass urine afterwards. Because if the bladder tears, urine leaks out. He will not be passing any urine afterwards. So he will say, I have not passed urine. I am not able to pass any urine. Any patient after trauma, if he is unable to pass urine, you think about bladder rupture. Okay, so he will not be able to urinate. So you'll be like, okay, maybe bladder has ruptured, maybe. So what you will do, you will examine him. What will you see when you examine? You have to see first urethra or urethral meatus. So when you will see the urethral meatus, it will be clear. No blood will be visible. So what does it tell you? It tells you at least urethra to nahi phuti hai. So there is no blood seen at urethral meatus. This tells you probably urethra is not ruptured. Mostly it is bladder rupture. And the second thing that you will see is you will see evidence of peritonitis. So you will see some distension of abdomen. Maybe he will have rigidity and so on and so forth. So there will be distension. There will be rigidity, signifying peritonitis. Simple. So this is how you get an idea that he has a intraperitoneal bladder rupture. This is the first part. But sometimes what will happen is the injury will not be like this to the roof. The injury will be to the pubis. And this force will go and tear the wall over here. Lateral wall will tear. So if the lateral wall will tear, then the urine will not go to the peritoneal cavity. Urine will leak here. It will start collecting here in this area around the bladder. It can't go down because you have pelvic floor, you have levator ani. It can't go in the peritoneal cavity also. So it will start collecting around the bladder. So in the second scenario, there is injury to pubis. And there is a tear of lateral wall. So here, what will happen is this is called as extra peritoneal rupture. And here there is no peritonitis. Here you will have urine collecting around the bladder. So urine will leak in perivesical space. Perivesical space. What is the name of the space? The space around the bladder. It cannot go down. It cannot go up. Because up there is peritoneum. Lower there is levator ani. So it will be all around the bladder. This is called space or cave of Retzius. Okay, this is called cave of Retzius. आई बात समझ में? तो in intraperitoneal bladder rupture, there is peritonitis. Extraperitoneal rupture, no peritonitis. Urine will leak in the cave of Retzius. जो आपको काफी बार पता भी नहीं चलेगा. Normally you don't even come to know. So when I examine this patient, when he comes to emergency, he will have the same finding. He will have history of injury to the pubis. He will say not able to urinate because bladder is ruptured. I will examine him he will also show no blood at meatus because urethra nahi puti. But abdominal examination, there will be no distension, rigidity, peritonitis, क्योंकि इसमें peritonitis है ही नहीं. So then how do I know whether bladder has ruptured intraperitoneally or extraperitoneally? For sure, what should I do next? पता कैसे चलेगा कि ऊपर फटा है या साइड में फटा है? What is the next step? USG, no, you will not do USG. So what you are going to do in both these cases is you are going to put a catheter. You will put Foley's. See, you can put Foley's only if there is no blood at meatus. If you see blood at meatus, you can't put Foley's. So only if there is no blood at meatus, you will put a Foley's catheter. And once you put the Foley's, you will inject a contrast in the bladder. What is this called? This technique? You are injecting contrast in bladder. What is this called? This is called as ascending cystogram. Okay, this is called as ascending cystogram. Ascending यानी नीचे से ऊपर डाला मैंने contrast. It's not come from the top. It has gone from urethra into bladder. Cystogram means looking or viewing the bladder. So cystogram. So I do ascending cystogram. When I do ascending cystogram, I can get an image like this. So solve this question. What image is this? Just tell me the image. Don't tell me the diagnosis. An ascending cystogram will look like this. What is the diagnosis? You see contrast in bladder. Is it a normal contrast? So normally, when I put contrast in the bladder should have a full outline, uniform outline. I don't see that here. What I see here is यहाँ तक तो सब सही है, but here I see vague outline. That means the contrast is leaking upwards. So what has happened here? This case is a case of intraperitoneal bladder rupture. If it was extraperitoneal, then the contrast will leak from the side over here. जो इसमें नहीं दिखा. ठीक है? So here contrast is leaking upwards, so it is intraperitoneal rupture. So basically, when I do this ascending cystogram, I come to know, is it intraperitoneal rupture or is it extraperitoneal rupture? फिर करूंगा क्या मैं? If it is intraperitoneal rupture, what should I do? And if it's extraperitoneal, what should I do? Urine is leaking into the peritoneum. So if urine leaks into the peritoneum, he's having peritonitis. I will do laparotomy and bladder repair. Because जैसे intestine perforate हुआ, you do laparotomy repair. Here also, bladder is perforated, urine is causing peritonitis, you will do repair. What do you do in extraperitoneal rupture? इसमें repair करना बहुत मुश्किल है. Extraperitoneal rupture ना, जो यहाँ होती है, from the side, you can't reach this area. ये तो मैं पहुंच जाऊंगा laparotomy करके. This area I can't reach because it is retropubic, very difficult to reach. So going there, suturing it, very difficult. So if it is extraperitoneal rupture, I don't do surgery. I just keep the Foley's for 8 to 10 days. Keep it in place and the rupture will heal by itself. क्योंकि इसमें peritonitis नहीं है, तो मुझे कुछ करने की जरूरत नहीं. Yes, there is some urine leaking, but that over time will get absorbed. So if I keep catheter, urine will come from the catheter and slowly, the bladder may wherever the tear was, it will heal. So treatment for extraperitoneal rupture is going to be just keep the catheter. Nothing else has to be done. Right? If Foley's can't be removed, that means the bulb is not getting deflated. You can puncture the bulb, ultrasound guided. So what is the answer to this? Patient presents with hip fracture, no blood at meatus, means it is not urethra, it is bladder. You put a catheter, you did this image, I told you this is intraperitoneal rupture. So the treatment is going to be laparotomy and okay, laparotomy and repair. This is going to be done for extraperitoneal rupture or urethral catheterization. That will be the treatment for extraperitoneal. Don't worry about what is SPC करेंगे. We are not there yet. अभी के लिए इतना समझ लो. IP rupture, laparotomy and repair. EP rupture, keep the Foley's. The rupture will heal by itself. Okay, fine. I said just now, Tokyo, don't worry about SPC right now. Okay, don't worry. Be patient. Sabar karo. Now come to the second part, which also is tricky, but becomes easier if you know the anatomy. And I'm talking about male urethral rupture. Okay, female urethra is very short. Normally it doesn't rupture. The male urethra rupture कैसे होगी, कब होगी, ये भी simple anatomy से समझना. Very simple. So again we go the same way. I have bladder, I have prostate, I have this prostatic urethra over here. Then I have this levator ani. This is the membranous urethra. The urethra now, it takes a turn. Okay, be very careful about this. It takes a turn. This urethra, which is turned C-shaped, this is the bulbar urethra. Okay, so ये जो urethra है ना, जो C-shaped है, that is the bulbar urethra. Beyond this will be the penis. Okay, and inside the penis will be the penile urethra. Penile urethra normally doesn't rupture, so don't worry about it for now. The skin over here of the abdominal wall will continue towards the root of the penis. This is the levator ani going up. Here will be the scrotum. Okay, अभी के लिए इतना. Behind the bladder is the rectum, which also has the pelvic floor. Then I have the anal canal. Okay, this anal canal where it gets over, you know, is called the anal verge. This anal verge will continue with the scrotal skin over here. ठीक है, आई बात समझ में? तो ये आपकी एनाटॉमी. यहाँ मैंने ऊपर का कुछ नहीं बनाया, उसकी जरूरत नहीं. So here you have the peritoneum. Okay, not needed. Now we are talking about urethra. There are two parts of urethra that you need to know. The first part is this part, prostatic membranes. That prostatic membranous urethra, this one, is called the posterior urethra. Posterior means prostatic plus membranous. Okay, जो प्रोस्टेट के अंदर है प्रोस्टैटिक, जो स्फिंक्टर लीवेटर एनाई के बीच में मेम्ब्रेन्स, उसके आगे की दिस यूरेथ्रा which is in the shape of a C, that is called as the bulbar urethra. Okay, so bulbar urethra is below the levator ani. Now when will the urethra rupture? Yes, any idea? Urethra कब rupture होगी? You know when bladder will rupture. When will urethra rupture? So bladder ruptured when bladder was full. Injury to lower abdomen, inflated bladder at the time of injury. When will urethra rupture? So urethra will rupture when there is injury to lower abdomen, injury to pelvis, or even injury to the perineum, and bladder should be deflated, because if bladder is deflated and I get an injury there, urethra will tear. Bladder will not tear, urethra will tear. So there should be deflated, bladder should be empty at the time of injury. So when the injury happened, bladder was empty. So because bladder was empty, bladder didn't tear, maybe urethra too. Now how will urethra tear? आगे का part is very easy. इतना ही part समझना था, बाकी सब easy. Injury can happen in two ways. First injury was similar. I get a blow to the pubis, but bladder is non-distended, bladder choti thi. So bladder will not tear. This force will go and tear the urethra here. This urethra will tear, posterior urethra. And if the posterior urethra will tear, the urine from the bladder will leak over here. Where is it leaking? In posterior urethral tear. Because now it is tearing above the levator ani. Where is the urine leaking? Very good. Cave of Retzius, same extraperitoneal. Just like your extraperitoneal bladder rupture, urethra, here it is leaking in the cave of Retzius. So ये हो गया पहला part. So let's write this first. That there is injury to pubis on empty bladder. Because the bladder was full, bladder will rupture. Now bladder will not rupture, urethra will rupture. So if there is injury to pubis on empty bladder, there will be a posterior urethral rupture. History पे ही आपको ये सब पता चल जाएगा, पता है? You will have a posterior urethral rupture. This posterior rupture, the urine will leak in cave of Retzius. Perivaside. How will the person present if the urine is leaking there? Presentation क्या होगी? So in this case, when the person comes to emergency, he will have history of trauma. He will say, since the injury has happened, I am not able to micturate. So not able to micturate, two scenarios, bladder rupture, urethral rupture. So he will be unable to urinate. So you'll be like, okay, is the bladder ruptured or is the urethra ruptured? So you will examine him. So what will you see? Very important. You will see blood at meatus. It is the most important sign. Blood at meatus. If there is blood at meatus, urethra has ruptured. It's only whether it's posterior or anterior. But blood at meatus, urethra has ruptured. बात खत्म. बाकी कुछ finding नहीं मिलेगी. There will be no peritonitis. Sometimes, if you do a per rectal exam in this patient, you get a finding. You get what is called as floating prostate. So if you put your finger in the rectum, you get a floating prostate on per rectal exam. That is called as Vermeulen sign. So clinically also I come to know it is a urethral rupture, not a bladder rupture. On the other hand, now this is very different. The next kind of rupture. Let's say the injury is to the perineum. Yeah. Perineum में injury कब होती है? Someone kicks you in the perineum, or bicycle पे आप गिर गए, bicycle injury, or you are working out in the gym and you fell like this on the dumbbell or the barbell. If you see in Bailey, they will give you a picture of a man slipping on a manhole. So the manhole goes and strikes against his perineum like this. His leg split and it hits him like this. So here the injury is very different. It's an injury to the perineum. Perineum माने क्या? ये नीचे वाली एरिया. यहाँ पर. So यहाँ पर जब इंजरी होगी ना, injury to perineum, this force will go and tear this urethra. The tear will be in this urethra, bulbar urethra. So now whatever urine is in the bulbar urethra will start leaking in this area. And from this area is called the superficial perineal pouch. Perineum की superficial area. It will go in the superficial perineal pouch. Then it will track into the scrotum. Then it will track into the penis. It will never go in the cave of Retzius. वहां नहीं जा सकती because there is a pelvic floor. So second scenario is when there is injury to perineum. And here it doesn't matter bladder was full or not. If there is an injury to perineum, there will be tear of bulbar urethra. And if there is a tear of bulbar urethra, the urine will leak in the superficial perineal pouch, and from superficial perineal pouch it will leak into the scrotum or penis, the subcutaneous area. But so this is very classical, it is unmissable. अगर किसी को पेरिनियम में इंजरी हुई तो बात ही खत्म हो गया. It cannot mimic anything else, right? It cannot mimic anything else. Simple है. So here, when he comes to emergency, he will come to history of injury to perineum, and when you will examine him, here also you'll have blood at meatus, so urethra is ruptured. But you want to know, is it anterior or posterior? Is it bulbar or posterior? So what you will see? You will see perineal hematoma, because that's where the injury happened. You will see urine leaking, or you will see swelling in the penis, swelling in the scrotum. So scrotum and penis will be swollen. So simple. Anyway, if I want to confirm the diagnosis, what has ruptured and how, so how will you come to know? Generally asked, what if something history mentioned fall from height, which urethra rupture? No, generally nahi पूछ सकते. You need more information than that, because both of the things can happen. If there is blood at meatus, what is the one thing I can't do? So if I see blood over here at the tip of the meatus, यहाँ पर मुझे blood दिखती है, तो मैं क्या नहीं कर सकता हूँ? Because I want to know, is it leaking from here or is it leaking from here? Where is it leaking from? So I can't put a catheter. Okay, catheterization is contraindicated. तो कैसे पता चलेगा भाई कहाँ से लीक हो रहा है? कॉन्ट्रास्ट कहाँ से डालूं मैं? कहाँ पे डालूंगा कॉन्ट्रास्ट? So what I do in this cases, I don't put Foley's. I just put the tip of the Foley's. इतना थोड़ा सा. I just put the tip of the Foley's in the urethra and I inject contrast and take X-ray. So what will happen? Contrast will go like this. Either it will leak from here or it will leak from the top. So then it becomes easy. So remember, I am not putting contrast in the bladder. I am putting contrast at the tip of the meatus. That is called as ascending urethrogram. Okay, it's not cystogram. Ascending urethrogram. ये आपके एग्जाम में पूछते हैं. प्लीज डोंट से सर ये सब क्यों पढ़ा रहे हो, बहुत चीजें पढ़ानी है, ये सब मत पढ़ाओ. ये तो पूछते हैं एग्जाम में. So you can see how it looks. They put contrast in the urethra. Normally it goes like this into the bladder. Now see over here, it's going like this and then it is leaking. So this is a urethral rupture. Which urethra is ruptured in this image? The second image. Which part of the urethra is ruptured? Bulbar. Okay. Why do you say bulbar? What did I say is bulbar? When I told you bulbar urethra, what did I say is bulbar urethra in this image? The C-shaped urethra, the curved urethra, not the straight urethra. Which urethra is leaking here? Is it the C-shaped curved urethra or is it a straight urethra? Bulbar urethra is this. This is the straight urethra, means it is prostatomembranous urethra. This is a posterior rupture. Okay, it's not anterior. In your FMG just this year, they had asked about a stricture. ऐसी image थी, it was a stricture. It will not be bulbar if it is not in the bulb. This curved urethra is the bulbar urethra. Okay, if it is the straight urethra, it is the posterior urethra. Okay, आई बात समझ लो. तो ये mistake इस exam में आपने करी थी, मत करना. So ascending urethrogram will tell you what type of rupture it is. Is it a posterior rupture or is it a bulbar rupture? But luckily or unluckily, it doesn't matter what the rupture is, because the treatment is the same. The treatment for both is the same, no problem. All you have to do is, when bladder becomes full, so bladder एक बार भर गया urine से, when bladder fills with urine, you will do suprapubic cystostome. Okay, so someone was asking suprapubic cystostomy क्यों नहीं? SPC cannot be done in bladder rupture. अगर bladder फूट गया है, आप उसमें catheter कैसे डालोगे? To put SPC, bladder has to distend. Only when it distends will you put SPC. So here, once the bladder gets filled with urine over time, you will put SPC. SPC is basically from here, above the pubis, you put a tube directly into the bladder. SPC tube. And urine comes out from here. It can't go niche because there is a rupture. It will come out from this tube. That is called SPC. But SPC can only be done if the bladder is distant. Right? Okay. What about the rupture? SPC is temporary. Urine will come out from SPC. उसके बाद क्या? What about the rupture? The rupture heals by itself, but it will form a stricture. So this is not bladder rupture. This is urethra. It's a tube. Whenever a tube will tear, the site where it heals, it may form some narrowing. So you may have to do a urethroplasty or a urethral repair. But this repair will be done after 2 to 3 months. Which means 2 to 3 months के लिए patient will live with suprapubic cystostomy. And suprapubic cystostomy के बाद, eventually, once the stricture forms, you will take it out. ठीक है? आई बात समझ में? पोस्टीरियर और बल्बार का एरो सेम है क्योंकि दोनों का ट्रीटमेंट सेम है. So whatever it is, whether it is posterior rupture, urine leaking from here, or whether it is bulbar rupture, treatment is the same. So you can't make a mistake in the treatment. Answer this. Answer this. Easy question, but students make mistake in this. If सब इतने confidently अभी A लिख रहे हैं. Man is brought to the emergency. He fell in manhole. Injured his perineum. You see, injured his perineum. आगे सोचना भी नहीं है. He is unable to pass urine. That means कुछ तो फूटा है. There is blood at tip of meatus, means it is urethral rupture. There is swelling in the perineum, swelling in penis and scrotum. Swelling in perineum, swelling in penis and scrotum. That means this is going to be a rupture of bulbar urethra. Okay, simple, no problem. अगर penile होता तो the history of injury would be to penis. When will penile urethra rupture? When? How will you get a penile rupture? पेरिनियल इंजरी में तो बल्बार यूरेथ्रा ही रप्चर होगा. सेक्स, अरे कौन से सेक्स में पेनाइल यूरेथ्रा रप्चर होगा यार? ये उसमें पेनाइल फ्रैक्चर होता है, यूरेथ्रा नहीं फूटती है. या डायरेक्ट ट्रॉमा टू पेनिस व्हिच कैन हैपन ड्यूरिंग इंस्ट्रूमेंटेशन. सो पेनाइल यूरेथ्रा कैन ओनली रप्चर ड्यूरिंग इंस्ट्रूमेंटेशन. सो कैथेटराइजेशन, यूरेथ्रल डायलेशन, ऐसा कुछ करोगे तो पेनाइल यूरेथ्रा फूटेगा, वरना नहीं होगा. ट्रॉमा से नहीं होगा. अश्लील लोग हैं आप लोग, बहुत ही अश्लील हो. पीनस ईटर, ऐसा कुछ होता है क्या? पीनस ईटर. फोरेंसिक की क्लास हुई नहीं है. आप लोग ना सबसे ज्यादा फोरेंसिक में एंजॉय करोगे. सर्जरी को तो पूरा अश्लील ही कर दिया है. चलो आंसर बताओ इसका. ओके, 10-year-old boy skids while cycling. Child was stable. Blood was noticed at the tip of meatus. What is the next best step? हो गया forensic. Okay, I think that's why. Next step, this is urethral rupture. You will do SPC. Foley's is contraindicated. Okay, please don't do Foley's. Answer to this. Similar question was asked. Very similar. There was an image where they asked you the site of the stricture. ये तो आसान है फिर भी. Child is having problems in urination. Dye is introduced from urethra. To visualize the fault, so they have put the dye from below upwards. What image is this? This is retrograde urethra. Okay, how do you do micturating cystourethrogram? ये कैसे करते हैं? Someone was asking when I was talking about IVU. Someone was screaming MCU, 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 MCU. कैसे करते हैं MCU? While peeing. अरे लेकिन contrast कहाँ से जाएगा? While peeing, लड्डू भाई. So to do MCU, there are two ways. If I want to do MCU, Either I give IV contrast or I put Foleys and inject contrast. Okay, but then I remove the Foleys. The X-ray is taken when he is micturating. That's why it is called micturating cystourethrogram. It looks like this. ऐसे दिखता है MCU. You will see full bladder and little contrast entering the urethra. अगर आपको bladder ज्यादा दिख रहा है, bladder seen much more than urethra, then think about MCU. And they will describe to it how it is done. Here, what you see, contrast you can only see over here. Barely any contrast in the bladder. Bladder to barely dikh. So this is going to be ascending or retrograde urethrogram. What is the site of stricture in this image? Where is the stricture in this image? Pelly valley. Excellent. See, now you're using your brains. That's why you're getting the answer. This is the curved urethra. Stricture is over here. So curved urethra. This is bulbar urethral stricture. Okay. Here also, the stricture is over here. Bulbar urethral stricture. So easy. Prostatic membranous will be straight urethra. Okay. You can never say for sure, because these are all anatomical landmarks, but you can never say for sure. You may be wrong. Best way to know is by doing endoscopy. Why so white bladder? Because contrast is in the bladder. That's why. Okay. So it's because of the contrast. So that was about bladder rupture, urethral rupture. They are actually very tough topics. Okay, they are actually very tough topics, but now I don't think you should make mistakes in them. Treatment of stricture, there are many treatments. You can do dilation, you can do stricturoplasty. So don't worry about that. Both सारे treatment है उसके. Now come to something easier. Prostate, which is a common disease and can come in the exam and easy to understand if you know only one thing. एक ही चीज पता होनी चाहिए इसमें in prostate. You only want to know one thing, the anatomy or the lobes of prostate. So prostate is over here, this part, just below the bladder neck. This is the prostate. Okay, it's a gland which is surrounding the urethra. So the prostatic urethra lies within the prostate. So if I cut the urethra, cut the prostate like this, if I cut it like this, and I see it in cross section, it looks like this. So prostate, if I cut through and I look at it grossly, it will look like this. There will be two lobes laterally. So ऐसे there are two lateral lobes. Okay, there is little bit of anterior lobe here. These are the lateral lobes. Inside the lateral lobes over here will be the urethra, prostatic urethra. Behind the urethra here, there will be a median lobe of prostate. Median एक ही होता है. And behind the median lobe over here, will be the posterior lobe. Okay. From here, there are two ducts which open into the urethra. What are these ducts? Which open into the urethra, which go through the prostate, open into the prostatic urethra. What are these ducts? They are called ejaculatory ducts. So they will contain seminal fluid and all those things. So you have the ejaculatory ducts which enter the prostatic urethra. Now coming to the problem. Urethra is within the prostate. So diseases of the prostate can directly impact the urethra. They can directly impact, they can compress the urethra. There are two diseases. One is the benign enlargement, the EP. Benign enlargement is a tumor of the prostate which is benign. So it's a benign tumor. Actually, it is a type of a prostatic adenoma. Like how you have pleomorphic adenoma, you have prostatic adenoma. This adenoma comes from which part of the prostate? The prostatic adenoma comes from where? BEP, BPH same here. Same. BPH ये word है ही नहीं. It is only BEP. So this adenoma normally comes from the lateral lobes. Normally. Sometimes from the medial lobe. One of these three lobes. And as the adenoma will grow, you can see it will start compressing the urine. The problem is BEP arises from lateral lobes, which is called as transitional zone, or median lobe, which is called as central zone. And because it is arising to the urethra, it will cause urethral compression. So the main problem with benign enlargement is early urethral compression. So an elderly man who comes with these urethral compression problems is having an enlarged prostate. Simple. So if your father or grandfather, they have to wake up at night many times to go to the washroom, or they have to keep going to the toilet many times in the day, they can't hold it, they are probably having an enlarged prostate. Benign enlargement. It's a prostatic adenoma. So the main problem in this is going to be there will be urethral compression. Because of urethral compression, there will be bladder distension. So bladder will also have to work more. And because of bladder distension, the urine in the bladder may get stuck sometimes. So he may get retention of urine. He may get urinary tract infections again and again. So he may get UTI. He may get bladder stones because the urine is getting stuck. And he can get problems in the ureters and the kidney. He can get bilateral hydronephrosis. Hydronephrosis when the kidney, the collecting systems of the kidney, the renal pelvis, the calyces, they become dilated. That is called hydronephrosis. And this can lead to chronic renal failure, CRF. तो ऐसे मत सोचना कि प्रोस्टेटोमेगाली से सिर्फ प्रोस्टेटिक प्रॉब्लम्स होंगे. It can get much worse. Okay, it can get much worse. You can get problems going all the way to the kidney also. Now, normally, how does this person present? Normally, clinically, this person will usually be more than 50 to 60 years. Obviously, a man, no context, no other way. And he will come with urinary symptoms. And these symptoms are what are called as LUTS. LUTS means lower urinary tract symptoms. LUTS. So he will have symptoms like increased frequency, urgency, nocturia. Nocturia means he has to wake up at night to pass urine. Even if he has to pass urine one time, even if it is one time, it is nocturia. So एक बार भी अगर वो उठा ना रात को सोने के बाद, it can be called as nocturia. So he gets these symptoms. He may be have to strain. So there is excessive straining. So every time he passes urine, he has to put some force. The urinary stream is very poor. Stream is weak. Sometimes he may have urinary incontinence. So there are a lot of urinary problems that the person comes with. So if your father or grandfather is having these kind of symptoms, 99% they are having prostatomegaly. And this goes on for several months, sometimes even years. कि बार-बार पेशाब करने जाना पड़ रहा है. It's quite frustrating. Obviously, more than anything, it's frustrating. Then they may get stones, they may get strictures, they may get renal problems. Problematic. Patient comes with this. What will you do first? What investigation will you do first? सबसे पहले What if these symptoms are females? Then it is something else. Obviously it's not a BEP. In female, urethral stricture हो सकती है. तो सबसे पहले you will do a rectal exam because you want to feel the prostate, feel the enlargement of prostate. तो पहले rectal exam करेंगे. You will put the finger, you will feel yes, it is enlarged, but it will be formed. Okay, it is enlarged, but it is formed, and you can feel the prostate on rectal exam. Then what you are going to do? What is the next step? So you have to do two things. The first is you are going to do serum PSA levels, because you want to rule out CA prostate. So you will do serum PSA levels. And the second thing you will do is you want to see, has the prostate really enlarged? For that you will do USG prostate. तो उसमें आपको दिख जाएगा that it is enlarged prostate. Simple. Biopsy normally is not required. So normally you won't have to do biopsy to say it is a benign enlargement. Doubt है तो कर सकते हैं biopsy. Normally नहीं करते. So normally if PSA is very high and prostate is hard, you think, oh, it can be cancer, then you do biopsy. Otherwise, it's not a must. Otherwise, ultrasound prostate is enough to diagnose benign enlargement. All right. So you will think about CA prostate, then you do biopsy. I hope that answers your question, Gursimran. Anyways, how do you treat it? Treatment is easy. You must have learned most of it already. Before I'm teaching you, you should be teaching me. So the treatment, the first treatment line of treatment is going to be medical. Okay, I won't discuss this too much, but you start with medical treatment. So there are two groups of drugs you can give. The first one are alpha-1 blockers, and the second group of drugs are the 5-alpha reductase inhibitors. आज के ज़माने में most people are controlled with the drugs. Like how for peptic ulcer you get PPI, for GERD you give PPI. These drugs are going to suffice for most of the patients. Okay. Alpha-1 blockers, the commonly used one is tamsulosin. Pharma में पढ़ा होगा. 5-alpha reductase inhibitors, you have dutasteride. Pehle they used to use finasteride. Now they use dutasteride. Okay. Most people will be happy with this. Surgery is not needed. So my question is, when will you send the patient to urologist? When will you do surgery? I will not be interested in what the surgery is. Whatever I have taught you, I only asked you when surgery, not what surgery. When surgery. So when will you do surgery? Medical management fail. Very good thinking. So the most common indication for surgery is patient is having severe symptoms. Patient is having severe symptoms. He is having a low urine flow rate. You can measure what is his urine flow rate. If it is very low, that means he should undergo surgery. Second is, if he has any complication, you should do surgery. तो वही किया ना, complication और severe symptom हर जगह पे आपने यही टिका है. Symptoms, complications, cosmesis, patient wants, बस तो वही करना है. If patient says नहीं हो रहा, नहीं जम रहा, मैं रात में 5 बार उठता हूँ पेशाब करने, बस हो गया, निकाल दो प्रोस्टेट, निकाल दो. ओके, सर्जरी एक ही है, एक ही सर्जरी करनी है. दैट सर्जरी इज कॉल्ड TURP. TURP is transurethral resection of prostate. Okay, that is TURP. Like you did TURBT, transurethral resection of bladder tumor. Here you will do TURP. Simple. So TURP is nothing but with the help of cystoscope, you cut out the prostatic tumor, the prostatic adenoma. So cystoscopy से कर सकते हैं. एक दो चीजें ध्यान में रखनी होती है, that there is a time limit for the surgery. The time limit. This surgery should be completed ideally in less than 60 to 90 minutes. If the surgery gets prolonged, the person gets a problem that is called as TUR syndrome. Okay, so surgery has to be done. This is one of the few surgeries in the whole of general surgery where there should be a limit to how much time you can do the surgery for. You cannot keep going at it. Because the problem is, when I'm doing this surgery, it is done with the help of a cystoscope. यहाँ पर prostate, and I put the cystoscope to cut it. So my endoscope goes like this. Okay, and I'm cutting it. Problem is, throughout the surgery, I have to keep flushing the bladder because every time I cut, it bleeds. So I have to keep irrigating some fluid inside. And whatever fluid I put in the bladder gets absorbed from the bladder. So if my surgery goes on for very long, 2 hours, 3 hours, in 2-3 hours, I may have flushed 5-6 liters of fluid. So person will have absorption of 5 to 6 liters of fluid from the bladder. Bladder से absorb भी होता है. Bladder is not only storing urine. If you put normal saline in the bladder for a long time, it will absorb it also over time. So a person can land up with fluid overload. That is the main problem. So to avoid this, you will use time limit and the fluid you use for irrigation to avoid this. The irrigating fluid should be glycine. Glycine will also reduce the risk, but glycine is not easily available. हर जगह मिलता नहीं. Normally people use distilled water, उससे problem हो जाएगा. Right? So this is what you have to do, and this is the problem of TURP that you should know. The other complication, which is the most common complication, is during surgery, you can injure the internal sphincter. This happens in practically every patient. There can be internal sphincter injury. What happens if internal sphincter is damaged? Because someone asked me, na, can his sexual function be intact after this? Prostate ही निकाला है और कुछ तो नहीं किया है, testis तो वही है. Cannot control urine. No, see, understand. Internal sphincter does not control urine. External sphincter controls urine. Remember, I told you in fistula and ano, everything is external. Internal, itna problem nahi hai. The problem with internal sphincter is if it is damaged, you will get retrograde ejaculation. So what will happen is, when he will try to ejaculate, he will feel the climax. So he will feel, yes, I have come, but nothing will come out because the semen will go into the bladder. So he will feel, okay, oh, I climaxed, but nothing came out. Where has it gone? It has gone back. So this will lead to fertility problems. It will not lead to sexual problems. Okay, fertility issue होंगे. But then these people are going to be 60, 70, 80 years old. I think they can be okay with it, right? It's no big deal. If the semen doesn't come out when they ejaculate, I think it's okay, right? So not a big deal. Bigger problem, TUR syndrome. That should not happen. Similarly, a simpler disease is CA prostate. This is the most common malignancy in men after 60 years of age. So in elderly men worldwide, this is the most common cancer, which is why you should know a little bit about it. You can't run away from this cancer. It is the most common cancer in men after 60 years of age. Will we come out from bladder through urine? Urine में semen दिखेगा थोड़ी आपको पता ही नहीं चलेगा. So कुछ मिनट बाद जब वो urinate करने जाएगा, तब वो देखेगा थोड़ी कि यूरिन में आ रहा है क्या मेरा semen, because it will all get diluted, unfortunately, है ना? So CA prostate, CAP is CA prostate, most common cancer in men after 60 years. This CA prostate comes from the peripheral lobe. Okay, it will come from the peripheral lobe or peripheral zone. It comes from here. So unfortunately, CA prostate happens over here or over here. It's very far from the urethra. So unfortunately, this patient will not come with these symptoms. Unfortunately, this will present very late. So the presentation is going to be not due to urethral obstruction. So how will he present if it's not due to urethral obstruction? पता कैसे चलेगा? External should not get damaged. Whatever happens, external sphincter को कुछ नहीं होना चाहिए. अगर external sphincter फोड़ दिया ना, तो पेशेंट का यूरिनरी कंट्रोल चला जाए और तुम्हारी प्रोस्टेट प्रैक्टिस खत्म हो जाएगी, क्योंकि वो सबको बोलेगा ये डॉक्टर ने मेरा प्रोस्टेट काटा और अभी मेरी पेशाब कंट्रोल नहीं हुई. सो नथिंग इन एनी सर्जरी, एक्सटर्नल स्फिंक्टर को कभी कुछ नहीं होना चाहिए, वरना खलास, योर करियर इज ओवर इफ यू किल द एक्सटर्नल स्फिंक्टर. नो, लाइसेंस जब्त नहीं होगा, नाम खराब होगा और कुछ नहीं. ओह या. So the problem is there is no urinary obstruction in this. So person will not come with urinary obstruction. Person unfortunately will present with metastasis. Unfortunately. And where is the metastasis? Lumbar vertebra. So many times these patients, they land up with orthopedic surgeon. So they get lower backache, and you will think maybe it is osteoporosis, maybe it is spondylosis. They keep getting treated for osteoporosis, spondylosis, fractures. Turns out it is a metastatic CA prostate. So patients will present with lumbar vertebral metastasis. So in your exam, if they want to talk about CA prostate, they will not give you frequency, urgency, nocturia. Those symptoms will not be there. If those symptoms are there, it is benign. If it is lumbar vertebral metastasis, it is CA prostate. Right? So ideally, how should you diagnose CA prostate? Ideally, this should be diagnosed on screening. Ideally. So on screening, you should do two things. So if there is your father or grandfather, if they are after 60, they should undergo the screening regularly. You have to do rectal exam. If there is a CA prostate, it will be stony hard. It will be a stony hard prostate. So, आपके father, grandfather, if you know you have health checkups where you go and get your whole body checked up. So, usme they always do rectal exam in a man. Always, because they want to know, is there a hard prostate? It's a part of screening. And the other thing you are going to do is going to be serum PSA levels. Normally, PSA should be less than 3.5. If it is between 3.5 to 10, this should be further investigated. If it is more than 10, it is likely to be malignant. So you can predict that the person has a CA prostate by just doing his PSA levels. अगर 10 से ऊपर है, very likely that it is CA prostate. Okay. Nonetheless, how will you confirm your diagnosis? Investigation of choice for CA prostate. Confirm कैसे करोगे? ये तो आसान है. Whether PSA is normal or increased. अगर suspect कर रहे हो, तो आपको prove करना है CA prostate है. So investigation of choice is called as TRUS with biopsy. TRUS is transrectal ultrasound. So normally you do ultrasound on the abdomen, but if you want to look at the prostate better, you put the ultrasound probe for anally. So you do a transrectal ultrasound, ultrasound probe goes inside, and then you do a biopsy from the rectum. So rectum से सुई डाल दो, prostate में एक दो pieces निकाल दो. Normally you need to take 12 pieces. So when you do this biopsy, you should get 12 pieces of prostate. Ideally. What will it show? CA prostate means which cancer will come? Prostate में कौन सी cancer होती है? Yeah, it will be adenocarcinoma. And then you will do staging. How will you stage CA prostate? Staging तो बता चुका हूं मैं आपको. You will do MRI for local and you will do PET scan. or distant. Here PET scan is very important because here you are looking for lumbar metastasis. बाकी कैंसर में हो ना हो यहाँ तो पेट स्कैन कराना ही है क्योंकि यू आर लुकिंग फॉर लंबार वर्टिब्रल मेटास्टेसिस. ये हो गया आपका डायग्नोसिस. ये लास्ट पार्ट इजी है, स्टेजिंग एंड ट्रीटमेंट. बुक्स में थोड़ा कॉम्प्लिकेटेड है, मैं एकदम सिंपल बताऊंगा. हाउ डू यू स्टेज एंड हाउ डू यू ट्रीट. सीटी थोरैक्स की जरूरत नहीं. सो हियर आल्सो यू हैव T1, T2, T3, T4. Okay, T1 means early. Early means before he has had any problems. कैसे पता चलेगा early cancer? मिलेगा कहाँ से आपको early cancer? You cannot wait for him to get urethral obstruction. By then it will be late. So early cancer pick up कैसे करोगे? This is going to be found incidentally. On screening means incidentally with increased PSA or after TURP. Means patient came with benign enlargement, you remove the prostate, उसमें थोड़ा cancer मिले by chance, incidentally मिले. That is ideal. T2 means the tumor is limited to prostate. So tumor has not spread anywhere. T3 means tumor has breached the capsule of the prostate or it has spread to seminal vesicles. And T4, like always, adjacent organs. SI. So ideally, you should pick up the tumor incidentally, ideally. Otherwise, if it's limited to prostate, it is fine. But if it has breached the prostate into the capsule or it has gone into seminal vesicles, it's a problem. So really speaking, the treatment is possible only for T1, T2. What will you do for T1, T2? T1, T2, CA prostate, surgery, followed by adjuvant chemo. Simple. So the treatment for this is going to be radical prostatectomy. See, life has become so easy in oncosurgery. You should become oncosurgeons now. Radical prostatectomy. You may add adjuvant chemotherapy. If it's T3, T4, treatment is difficult. Okay, here the treatment is difficult. So here what is done commonly is something very different. You can give neoadjuvant chemotherapy. You can give neoadjuvant radiotherapy also, but normally it doesn't work. Here what is done is called as androgen ablation. So prostate is a testosterone dependent tumor. Like how CA breast was estrogen dependent. So there you give tamoxifen. Here you will give anti-androgens. So here you will give drugs like LHRH, like goserelin. You may have studied this in infertility. You will give goserelin, or you will give androgen blockers like flutamide. So these kind of drugs will take care of the metastasis. They will shrink the metastasis. It's like a palliative treatment. Okay, so these are the drugs which are used. You can use other therapies also, chemo, radio also, but commonly this is the treatment. So for us, for exam, this is going to be the treatment for CA prostate. There is one exception to this rule. Okay, there is one exception to this rule. Since most of these patients are going to be 60, 70, 80 years old. If a patient is 80 years old and I want to do a radical prostatectomy, it's a very big surgery. Okay, खाने का काम नहीं है, बहुत ही major surgery है. So someone who is 80 years old, who is not very fit and he has an early CA prostate, doing a radical prostatectomy is too much. तो उनमें मैं क्या करता हूँ? So there is one exception. If patient is more than 70 years, he has an early CA prostate, T1 tumor. His serum PSA is less than 10. In prostate, you do that score. It is called Gleason score. It's a pathological score. If the Gleason score is less than 6, then Normally you would have done radical prostatectomy because it is T1. इसमें नहीं करेंगे, इसमें आप करेंगे surveillance. So what I am trying to tell you is, a very old man with a very early CA prostate, don't do surgery, do surveillance. Once the tumor starts growing, once T1 say it becomes T2, Gleason gets worse or PSA starts increasing, then think about radical prostatectomy. No need to do early because it's not necessary. Okay, yeah, it's not necessary. If the life expectancy is not so much, then you don't have to do radical prostatectomy. Okay, answer this. What is this? Yeah. So this we already did. Patient was having metastatic CA prostate. So incidentally CA prostate with metastasis. That means this is going to be M1 disease. What will you do? You will use Goserelin. Okay, androgen blockers or anti-androgens. Can we give androgen blockers? He doesn't need it ना, metastasis है ही नहीं, तो आप इसमें androgen blockers देके करोगे क्या? It's not going to prevent the CA prostate from growing. Okay. Now come to a very interesting disease, which is called undescended testes. Testes mein na, there are 2-3 very nice topics which they keep asking in the exam. So undescended testes is one of them. They love asking this. Some topics of testes are not there in the RR notes, some of them. So undescended testes ke pehle you should know how does testes normally descend, where it is formed, how does it descend normally. So normally testes gets formed in the abdomen over here. It is formed in the retroperitoneum. Then it comes out from the abdomen, enters the inguinal canal. Here is the deep ring. It travels the inguinal canal, leaves the superficial ring, goes into the scrotum, reaches the bottom of scrotum. This is how it normally descends. So when I say undescended, it should be arrested anywhere in normal pathway of descent. It should be somewhere in normal pathway of descent. That is important. So normal pathway means the testes can be somewhere here, upper end of the scrotum. This is the most common site, upper scrotum, high scrotal, or it can be in the superficial ring, inguinal canal, deep ring, or retroperitoneum itself. These are the other sites, but it should be somewhere in this site. So most commonly, it will be seen high scrotum, or it will be seen at the superficial ring. ये हमने hernia में किया है, superficial ring. Sometimes, very rarely, extremely rarely, the testes is found at some abnormal site. So it won't be found anywhere in this pathway. It can be found at some abnormal site, like this is a superficial ring. Sometimes it is found just above the superficial ring over here. So it's not in the normal pathway of descent. It is at some abnormal site. Sometimes it is found in the thigh over here. Sometimes at the root of the penis. Anywhere not in the normal pathway. That is called as ectopic. Ectopic means found at any site outside the normal pathway of descent. And this is most commonly seen just above the superficial vein. That is called superficial inguinal pouch. That is where it is normally found. Superficial inguinal pouch, just above the superficial ring. So don't get confused if they say testes is found at superficial ring, undescended. But if they say superficial inguinal pouch, जो उसके ऊपर होती है, then it will be ectopic. भटकी हुई testis. If the testis is undescended or ectopic, what's the big deal? Does it kill him? ठीक है ना, एक टेस्टिस ऊपर है एक नीचे, ये बड़ी बात है. What is the problem with undescended testes? No problem, right? So there are some problems. There are some problems. The first problem is this undescended testes is at increased risk of seminal. Okay. Second thing is if it is bilateral, then it may affect its fertility. So fertility may be reduced. And the third thing is many times along with the undescended testes, there is a indirect or a congenital inguinal hernia. So there will be a congenital inguinal hernia. This is what is commonly seen. Okay. So if the testis does not come down, you can't just leave it there because there is a much higher risk of seminoma. Seminoma is the type of cancer of testis. Right. So how will you come to know that the child has undescended testes? When should it be diagnosed? Ideally, कि दोनों में से एक टेस्टिस नीचे नहीं आई है या दोनों नीचे नहीं आए हैं, कैसे पता लगेगा? ज्यादा कब पता लगना चाहिए? Ideally, this should be found at birth. Ideally, should be diagnosed at birth. But if you are having home deliveries and all, so it may be missed. So the mother may bring the child at a little later age. So if the child comes later, not at birth, so if the child comes later, then what will you see? थोड़ा बड़ा हो गया बच्चा, तब आया, तब आप क्या देखोगे? नहीं, what will you see? Which will tell you it's an undescended testis. One ball, don't say one ball, you will say empty scrotum, but that scrotum will also be underdeveloped. Please understand, your scrotum develops because there is a testis inside it. If there is no testis inside it, the scrotum will not grow. So you will have an underdeveloped scrotum on the affected side. ऐसा होता है. This tells you yes, ये बीमारी उसको बचपन से. Okay, ये बीमारी उसको बचपन से. What will you do in this case? Okay, so you saw that one of the scrota is empty. What will you do? You want to know where the testis is, ideally. In whether it is ectopic, whether it is undescended, whether it is here or somewhere higher up. So you want to identify, you want to localize where the testis is. So to localize, you will do two things. One is you will do USG groin, and you will do, if you don't find it in USG groin, you will do CSCT abdomen. दोनों करने की जरूरत नहीं है, एक के बाद एक करोगे. Either you will find it in USG groin, USG पे मिल जानी चाहिए because normally testis is down only. It will either be in the upper scrotum or it will be in the inguinal canal. But अगर दोनों में नहीं मिला and they ask you in the exam, gold standard test, your favorite word, gold standard test, to localize the testis, answer is going to be surgical exploration. Okay, that is the gold standard test. Whether the testis is in the inguinal canal or in the abdomen, you have to do surgical exploration. So you open the groin, open the inguinal canal, find it. If you don't find it in inguinal canal, do a laparoscopy. Okay, so you have to find it where it is. Why do I have to find it? Because I want to bring it down. So ideally, when should I bring it down? Ideal age. Should I, if I come to know at birth, should I find it at, should I try to bring it down immediately? No. Before 6 months. So before 6 months can be birth also. Neonatologist tells me that one testis is missing. Should I do it in the first week? Q? Why 5-6 months? Surgery should be after 5 months, not 4 months, 3 months. आपका बच्चा है, आप कब करोगे सर्जरी? Wait for 3 months. Why? So please understand, if the child is premature, sometimes testes can descend by itself can descend by 3 to 4 months after birth. So if it has not come down at birth, doesn't mean it will never come down. It can come down after 3-4 months also. So you wait for 3-4 months. So ideally, you will do surgery at around 6 months, 5-6 months. अगर 4-5 महीने तक नहीं आई ना, तो उसको सर्जरी के लिए तैयार कर दो. सर्जरी में क्या करोगे? You will bring down the testes, which is called as orchidopexy. So wherever the testes is, whether it is in the abdomen or whether it is in the inguinal canal, free it, pull it down, take it in the scrotum and suture it so that it remains down. That is called as orchidopexy. What will you do if child presents late? If child presents late, late means he comes in puberty. मदर से कि बच्चे को दाढ़ी मुच्छी नहीं आ रही है, 14 साल का हो गया, 15 साल का हो गया. So when will you do it? Or what will you do? No, don't give pulsatile testosterone. If child comes late and the testes is atrophic, so obviously you do surgery only. But if the testes is atrophic, then you will remove it, orchidectomy. ठीक है. तो अगर टेस्टिस नीचे नहीं आ रही है और वो आया ही नहीं 8 साल 10 साल, it's possible that you may have to remove the testes. You cannot leave it higher up if it is atrophic. ठीक है. So that is about undescended testes. Easy topic. Okay, answer this. I have put this question in many of the FMG GTs, many, because I am sure students will struggle with this. सोच के आंसर करना. इतना, it's not as easy as you think it is. और दूसरों के आंसर कॉपी तो बिल्कुल मत करना. चलिए कुछ बत्ती. So 14-year-old boy, his left scrotum is empty. Left testis is found in superficial inguinal pouch. So it is going to be left ectopic testis. If it was left superficial ring, अगर ring होता ना, तो you would have said undescended testes. What is this word? Cryptorchidism. ये क्या word है? Cryptorchidism. Crypto means what? Cryptocurrency. Hidden. छोटा. Hidden. Lol. Absent. False. Okay. So cryptorchidism really means if both testes are not clinically evident. Okay, they are not clinically evident means scrotum is empty, inguinal canal is empty. What does it mean? Not clinically evident. It means both testes can be in the abdomen, can be. So both can be here in the retroperitoneum. Means bilateral undescended, both in the retroperitoneum, or they can be absent. That is called anorchism. Absent bhi hoye na, means they never developed. That also can be cryptorchidism. Okay, so crypto means not clinically evident on both sides. ठीक है, आया बात समझ में? कभी था ही नहीं. What is this interesting disease that you see in the image? Very nice disease. So this is no, it's not torsion. This is called varicocele. So in my testes, I have these veins which drain the testes. They are called the pampiniform plexus of veins. These veins, if they become dilated, so if you get a dilated pampiniform plexus of veins, these are veins that drain the testes. That is called as a varicocele. Like how you have varicose veins in the lower limb, those were dilated superficial veins. Here, these are dilated pampiniform plexus of veins. So varicocele. Who gets it? No, it's not epididyme orchitis. Who gets it? Who will get it? Can I get it? Ascites. No. If whether it is ectopic or undescended, you have to bring it down, boss. You have to bring it down. Idiopathic, congenital, Marfan, Jim. No. It is seen in young men. Young men means young like you. Okay, not young like me. It is seen in young men. It is seen more on the left side, left more than right. And if it is seen in an elderly man, मेरे जितना नहीं, मेरे से भी बड़ा. If it is seen in an elderly man, what is the reason? Why will an elderly man get it, especially on the left side? Injury? No. It is because of left RCC. So a left renal cell carcinoma can give you a left-sided varicocele. I'll tell you why and how. It's like this. So let's say these are my kidneys over here. Okay. Now understand how my renal veins are. Let's say over here is the IVC. On the right side, the renal vein goes like this. Left side renal vein goes like this. The testicular vein on the right side goes like this. So this vein comes from the testis. Here right, here left. But the left testicular vein goes like this. The left testicular vein. So left testicular vein goes into the left renal vein. Right testicular vein goes into the IVC. So if I have a tumor in the kidney, it can block this left renal vein. It will block the left testicular vein. He will get a left-sided varicocele. Okay? Right? Nothing to do with portal hypertension. उससे भी कुछ नहीं होगा. So an elderly man with a left varicocele, left RCC. Young man also normally get on the left side, but that is because of there is no particular reason for that. Why it is seen in young men. What is the problem and how will the person present? So he will present with dragging pain in the scrotum. So अगर आप में से किसी को scrotum में dragging pain है, सोच लो. And when you examine the root of the scrotum, you can feel the veins. It is called a bag of worms feel. So the veins feel like a bag of worms. And many times it can lead to oligospermia. So आप अपना semen analysis भी करा लेना कल परसों में. अगर oligospermia है तो सोच लेना. Okay. Ankit, hydrocele is very different. So it's nothing to do with any of the things that we are doing. Hydrocele is a disease of the scrotum, not of the testis. So you can get oligospermia or infertility. How will you diagnose it? How will you treat it? How do you diagnose? Diagnosis. How do you diagnose it? You want to see dilated amniform plexus of veins. So whenever you want to look at the veins, you will do a testicular venous Doppler. कोई भी vein की disease, do venous Doppler. Okay. Portal hypertension, portal Doppler. We did one more venous disease, varicose veins, lower limb venous Doppler. Here also you will do venous Doppler. And the treatment, you need to know only one treatment, that is called as percutaneous testicular vein embolization. Alright, only one treatment is needed, percutaneous testicular vein embolization. Simple. So what they do is, they put some, like how you do sclerotherapy, they put some chemicals directly into these veins. From the skin side, that's why percutaneous. That will cause the veins to get thrombosed, fibrosed, and then they will go. पहले के जमाने में सर्जरी करते थे, आज के जमाने में this is the treatment of choice, percutaneous testicular vein embolization. Fine? Sir, मुझे 6 साल पहले, we will treat it. Yeah, but you don't strip the veins. You don't treat them with laser. Will this cause ischemia? Veins को block करने से ischemia नहीं होती. Ischemia is of arterial origin, not veins. Vein block करने से ischemia नहीं होती. No, there is no. It is not pre-malignant. It's not pre-malignant. So young male with slight dragging sensation, bag of worms, but testis is normal. This will be varicocele. Okay, this is a very interesting topic. Acute scrotum. Very nice topic. Acute scrotum means this is typically seen in a child, not child like you, even younger than you. If you have a younger brother, it's seen in a child who comes with sudden testicular or scrotal pain. Sudden pain. Why will you get sudden pain in a scrotum or testes? बच्चे में क्यों होगा suddenly testicular pain या scrotal pain? So 2-3 reasons. The most important reason, most common reason is testicular torsion. Torsion of testes. Torsion means what? Your testes is supplied by a testicular artery and testicular vein. So your testes is over here, and it is having a blood supply. There is a testicular artery. There is a testicular vein. If the testes will twist, तो अगर ये testes घूम गई inside the scrotum, then the blood vessels will also get twisted. And if the blood vessels get twisted, this will lead to ischemia of the testes. So remember, when you had sigmoid volvulus, it was a closed loop obstruction causing obstruction, strangulation, gangrene, perforation. Here also something similar. Here also you will get, because of the twist, there will be ischemia. Right? So there is going to be ischemia. The main problem with torsion is it will lead to ischemia, leading to gangrene. Who is at risk of this? What is the risk factor for torsion? कौन से बच्चे को होगा torsion? आपको तो नहीं हुआ होगा, hopefully. That's why you are here. वरना आप बोलते अभी तक. Sports athletes नहीं होते. Nothing to do with athletes. I said young boys, child. This is in a child. Nothing to do with prematurity also. It is because of some anatomical defects in the testes. जैसे आप लोगों के दिमाग में डिफेक्ट है, वैसे कभी कभी कुछ बच्चों में एनाटॉमिकल डिफेक्ट होती है, जिससे आप लोगों में बिल्कुल सब्र नहीं है. वो बेचारा कब से बोल रहा है सब्र करो यार, नहीं है सब्र वैसे. So it's not a trauma, it's not because of trauma. There are some anatomical defects, like the testes is lying horizontally. That is called transverse testes. So testes is lying horizontally, transverse testes. Or there is a mechanism which is called as bell clapper mechanism, or high investment of tunica vaginalis. These are some mechanisms. मतलब कुछ anatomical problem होते हैं जिसके कारण torsion हो जाती है. It is called high investment of tunica vaginalis. So in these kind of problems, because of this anatomical defect, the testes can twist. So if the testes twist, what will happen is, clinically, the child will come with a child होगा. It will be a 8-9 साल का बच्चा, 12-13 साल का लड़का, छोटा ही होगा. He will come with acute scrotal pain. Okay, and when you are going to examine, it will be very tender. The testes will be very tender. So any young boy with acute scrotal pain, with tender testes, you will think about torsion. But there is one disease which can mimic torsion. What is that? There is one disease which can mimic torsion. तो बच्चा वो टेस्टिस को छूने भी नहीं देगा. आपने थोड़ा छू भी लिया ना तो बड़ी पेन होगी, because it is becoming ischemic. What mimics it? There is one disease which mimics it. The differential diagnosis. That is called as acute epididymoorchitis. Epididymoorchitis simply means the testis is inflamed, not because of ischemia, because of infections. This can happen because of mumps orchitis, बहुत सारे reasons. तो mumps भी हो सकता है, torsion भी हो सकता है, और अगर mumps है उसका इलाज है मेडिकल, अगर torsion है तो उसका इलाज है surgical. It has to be untwisted. So I have to decide that, boss, is it medical disease or surgical disease? What should I do? Very good, excellent. I do a very simple test. It is called Prehn test. Prehn, Prehn. Okay, name of the test is Prehn test. Prehn. So what is this Prehn test? It tells you simply lift the testes. तो टेस्टिस को थोड़ा हल्के से just lift it up a bit, little हल्के से. And when you lift up the testes, if the pain gets worse, दर्द और भी बढ़ गया, that means it is torsion. But on the other hand, if the pain reduces, that means it is orchitis. Okay, so it's a bedside test which will give me an idea whether it is torsion or whether it is inflammation. As simple as that. So when I lift it, if the pain gets worse, it means there is torsion. Because when I lift it, the blood supply becomes even lesser. उसकी blood supply और कम हो जाएगी lift करने से. तो ischemia बढ़ जाएगा, pain बढ़ जाएगी. That is called Prehn test. What will I do next? Next step. I think the boy is having torsion. What should I do? USG scrotum. What for? Why do I need to do USG scrotum? Doppler करना जरूरी है. So there are two schools of thoughts. I'll tell you the best answer. Next step is going to be scrotal exploration. But put a star mark over here. If I have a doubt, I'm not sure, then I will do testicular Doppler. Testicular arterial Doppler. But when will I do Doppler? If there is a doubt. Because Doppler will tell me about ischemia. ठीक है? So अगर कोई condition नहीं दिया है, if it is clearly sounding like torsion, go for exploration. But if there is a doubt, you're not very sure, then you will do arterial Doppler. Because the problem is, whatever I do, I have to untwist the testes. Within how much time? Untwist the testes. Means whatever जो घूम गया था, जो torsion हुआ था, ideally it should be untwisted within 6 hours. तो अगर बच्चा लेट आया है, ऑलरेडी 4-5 घंटे हो चुके हैं पेन शुरू होने से, and you will spend another few hours doing Doppler, then the chances of the testes surviving is very low. So you untwist the testes within 6 hours, see whether it is surviving or not. If it is viable, बच गए, put it back and fix it. तो अगर testes बच गई, you are lucky, child is lucky, you will do orchidopexy. If it has already become ischemic, अगर gangrene हो गया है, अफसोस कुछ नहीं कर सकते, तो testes निकाल दो, orchidectomy. Okay, which is why time is essential. 6 घंटे के अंदर, 1-2 घंटे के अंदर कर दिया ना तो 100% बचेगा. But usually within 6 hours, 6 hours is the golden period. उसके अंदर बचा लिया तो बच गया. 12-13 घंटे बाद आया ना तो नहीं बचेगा, मुश्किल. What should you do apart from this? There is something you should do along with this. दूसरे तो भी मान देना, very good. You have to do normal side orchidopexy. So be very clear about this. Affected side तो you will untwist and see. Normal side जहाँ पे torsion नहीं है, वहाँ पर भी आपको testes fix करनी पड़ेगी. Orchidopexy means fix it because these anatomical defects will also be there on the normal side. तो यहाँ भी open करो और कम से कम 1-2 prophylactic stitches ले लो so that वो future में twist ना हो. So you have to do a contralateral orchidopexy. Right? Okay, answer this. So yeah, 21-year-old boy, someone like you, little younger than you, in agony, sudden onset pain, redness, right testes looks higher than the left. ये क्या है? Right testes looks higher than the left. What is this? Just because I am teaching torsion, you are writing torsion. Right testes looks higher than the left means what? Yeah, excellent. This is called as Deming sign. So like there is a Prehn test, there is a Deming sign, where the affected testes, because of the cremastric muscle tightness, is a little higher. That is called Deming sign. So answer here is testicular torsion. The affected testes is a little higher because of the spasm of the muscles. Okay, that is Deming sign. Deming sign. Very good. Okay, very important topic. Fournier gangrene हर एग्जाम में पूछते हैं, इस बार भी पूछा था जस्ट नाउ ये वाले एफएमजी में. Fournier gangrene. What is Fournier gangrene? Very nice disease. I have made a very nice reel about it, 1 minute reel, a long time back. Okay, after Fournier I will give you break. ठीक है, 5 मिनट में हो जाएगा. Then you take dinner break. Right? ये कर लेते हैं. ये थोड़ा गंदा टॉपिक है ना, ये करने के बाद डिनर शांति से खाना. डिनर खाने के बाद ये टॉपिक नहीं करना आपको. It's one of the worst diseases a surgeon faces. The worst. Means if you really operate on a Fournier's gangrene ना, उस दिन क्या एक हफ्ते भर आपको खाना नहीं मिलेगा, खाना खाने का मन नहीं करेगा. One of the worst diseases. So what is Fournier gangrene? It is called as a synergistic gangrene of scrotum. It is nothing but a type of a gangrene of scrotum. Synergistic gangrene of scrotum. Or necrotizing fasciitis of scrotum. All fancy words, but actually easy. I'll tell you what it means. This is seen in people with poor immunity. Someone who is a elderly diabetic, uncontrolled diabetic. उन पेशेंट में होगा. कुछ तो उनमें रिस्क फैक्टर होनी चाहिए. Someone who is uncontrolled diabetic. So what will happen is when they have a trivial trauma. अभी scrotum में तो trivial trauma, the boys will know, happens all the time. You know, you're all the time खुजली तो करते ही हो. So if you scratch, there is trivial trauma. In you and me, nothing happens. But in someone with a poor immunity, the skin organisms enter the scrotum, right? So someone with a poor immunity, Staph aureus or streptococci will enter the scrotum. And what they are going to do is they will cause a vasculitis. And because of vasculitis, there will be a scrotum gangrene. And as the gangrene is happening, as more and more cells are dying, this will allow the anaerobes to grow. So the anaerobes will also start flourishing. So basically, your aerobes are killing the tissue, helping the anaerobes to grow. That is why they are acting in synergy. समझ गए? जैसे आप लोग में बिल्कुल सिनर्जी नहीं है ना, आप लोग तो पूरे डिसरप्टिव हो. मैं एक चीज पढ़ाता हूँ, बीच में कोई कुछ मांग लेता है. So that is not synergistic. Synergy means everyone is quiet. One person is helping the other. Like if I am writing something which you can't figure and someone writes, sir ने last word क्या लिखा है? Then someone from the audience answers, it means this, Ray. Let him continue. That is synergy. So organisms are showing more synergy than you are, unfortunately. However you wish to take it. So where these aerobes are creating an anaerobic environment. Anaerobes are multiplying, so both are helping each other. They are acting in synergy. That is why it is called as synergistic gangrene. Okay, synergistic gangrene of scrotum. So nice, so unique. But what is very important, there are 2 points. First point is it will be polymicrobial. Aerobe, anaerobes, both will be there. And second thing is testis is spared. Okay, so it will only affect the scrotum. That is why it is called fasciitis. Only the scrotum fascia, skin, subcute will be affected. It will not reach the testes. Testes will be spared. How will the person present clinically? Clinically, it's very obvious. He will come with this. So clinically, he will come with this wound, which will be seen on scrotum. It can also extend to the perineum. That's all in continuity. And there is so much of microorganisms there. Patient can be very sick. He may be having septicemia. So you may be having fever, hypotension, drowsiness, all because of septicemia. ऐसा नहीं है चलते फिरते आएगा वो. He may be unconscious also because of septicemia. Because there is so much of microorganisms. Someone help Shubhama. It's not uncontrolled OM. OM नहीं है. EM. जो मैं लिखते रहता हूँ आजकल DM for details. DM. So he will be a sick patient and he'll have a wound like this. Very clear, very classical. There is only one treatment that you have to do here. You have to do a debridement. Okay, so there is only one treatment that is called as debridement, means you remove all this dead tissue, all infected tissue. But remember, testes mat nikalna, testes will be spared. So please spare the testes, please don't do orchidectomy. So what will happen is, scrotum you will remove, how much ever is gangrene, testes will be left unsupported. They will be hanging in the balance. What is that called? आपने टेस्टिस के सारे कपड़े निकाल दिए ऊपर से. So yeah, that is called as shameful testis. Okay, shameful exposure of testis. क्योंकि आपने उसके सारे कपड़े कवरिंग उतार दिए. There is one more thing which can help you here, that is hyperbaric oxygen therapy. ये नीट पीजी में पूछा था. That hyperbaric oxygen therapy has some benefit in these kind of diseases. This carries a very high mortality because there is a very high amount of septicemia. Patient has a lot of sepsis when he comes because all this gangrene has all organisms which are continuously entering your bloodstream. So there is a high mortality in this. Okay. Another important topic, that is CA testes. Okay. This is again one of the cancers which has a good prognosis. So CA testes and thyroid cancers, differentiated thyroid cancers, they are the ones with good prognosis. Who gets CA testes? One risk factor I already told you, undescended testes. That is the main risk factor. And CA testes can happen in different age groups. Okay, so there are different types of CA testes. अलग-अलग age group में होगा. So you need to know the types, which ones happen in what age group. So first and foremost, the most common type is the seminoma. And seminoma normally happens in the 30s and 40s. 30 to 40 means मेरी उम्र में. This image that you see, this is a seminoma. Very demarcated pinkish white tumor which is compressing the normal testes. This is how seminoma looks. The other tumors are the non-seminomatous germ cell tumors, NSGCT. Usme there are different types, like there is a teratoma. Teratoma is something that can happen in you. So this is seen in 20s. So आप आपका check करते रहना. You may get a teratoma. Teratoma looks like this. You see these small spaces, they are called as the cystic spaces. That is seen in teratoma. And if the teratoma becomes very mature, you know what will be there? Teeth, hair, nails, those kind of things will happen if the teratoma becomes mature. All right. So if you feel some teeth over there, you know what it is. Right. Then there are other germ cell tumors like choriocarcinoma. This is a dangerous one, choriocarcinoma. Yolk sac tumors. Choriocarcinoma also gives cannonball lung metastasis. Okay, then there are other tumors, like there are supporting cell tumors like Leydig cell or Sertoli cell. They are quite rare. These are functional tumors, means they produce hormones. So they can lead to excessive masculinity or they can lead to gynecomastia. Right. So these are some of the things, other different types of testicular tumors. Most common will be seminoma, others will be non-seminomatous germ cell tumors. Usme you have teratoma. These choriocarcinoma yolk sac tumors are seen in children normally. Now come to presentation and spread. Testicular tumors, very importantly, can spread to scrotum, but that's very rare. So spread to scrotum, extremely rare. This will happen only if you do a scrotal biopsy. That's why you should not do a scrotal or a testicular biopsy. Only if you do a biopsy can the tumor spread from the testes to the scrotum outwards. So that's why biopsy is contraindicated. More importantly, tumor can spread to lymph nodes. Which lymph nodes does it spread to? Does it spread to inguinal nodes? Will the tumor spread to inguinal nodes? Yes or no? Because testes is right there, right? So no, inguinal lymph nodes are spared. So inguinal lymph nodes are not involved. Inguinal lymph nodes are involved in penile cancer, in cancers in the lower limb. In anal cancer, you will get inguinal nodes. Inguinal nodes here are not involved. CA testes will spread to para-aortic nodes. Those are nodes in the abdomen. So it will normally spread to abdominal nodes, para-aortic. This is very important. Okay, so the lymph node metastasis will be to abdominal nodes, not to inguinal nodes normally. So how will the child present? Typically, it will be a young man like you or a little more younger man like me, and you will present with a testicular swelling, and obviously it will be painless. So a painless testicular swelling is the common presentation, and sometimes if the tumor has spread to the abdominal nodes, if there is a spread to para-aortic nodes, then the person can also have a lump in abdomen. This kind of a presentation is possible. So a young man like you comes with a testicular swelling. What should you do first? What is the first step? Don't say biopsy because biopsy is contraindicated. What is the first step in a young man with a testicular swelling? So you will do two things when you want to investigate. दो चीजें करनी है. सबसे पहले तो आप करोगे USG scrotum, because you want to look at the testicular mass. तो mass दिख जाएगा, and you will do tumor markers. Tumor markers are non-specific, but you will still do them. You will do serum alpha fetoprotein, you will do beta HCG, and you will do LDH. These are the important tumor markers, which may be elevated in testicular tumors. Okay, may be elevated. हमेशा नहीं होते, कभी कभी होते. Like AFP is a marker of yolk sac tumor. Seminoma में normally elevated नहीं होता. Beta HCG is a marker of choriocarcinoma. Seminoma का कुछ इतना sensitive marker नहीं है, but LDH can be elevated in all testicular tumors. If this is elevated and USG scrotum shows testicular mass, what will you do next? Because see, you're not sure that it is a CA testis, whether it is seminoma or teratoma or what. वो तो दूर की बात है. कैंसर है या नहीं वो भी पता नहीं. So should you do staging for metastasis? PET scan, CT scan, all that? Answer is no. You will not stage the cancer because you don't know it is a cancer. Okay, अभी तक मुझे पता नहीं है कि ये कैंसर है. I am assuming because I can't do biopsy. In this case, what I do is called as inguinal exploration. So this is important. I will do inguinal exploration. Inguinal exploration means even though the tumor is here, this is the testis, this is the spermatic cord which goes like this into the inguinal canal, and let's say the tumor is here. Now you will, अभी तक हमने जब भी testicular disease के लिए operate किया, we went from here. It's total exploration. Here we won't do that. Here you are going to do inguinal exploration. Means you take an incision in the inguinal canal over here, and you pull out the testes and the spermatic cord. You examine the testes, but in the inguinal canal, not from below. So you do inguinal exploration. You deliver the testes. You examine it, and if need be, you take a piece and send for frozen section. You can do here also intra-op frozen. If you feel there is any doubt, you can do intra-op frozen. If it is a malignancy, then you will do a high inguinal orchidectomy. Means you will remove the spermatic cord and the testes from here, from the inguinal canal, not from the scrotum. So if it is malignant, you will do a high inguinal orchidectomy. And if it is benign, then good for you, good for the patient. Put it back. Put the testes back. Right. So a bit like how we managed a follicular thyroid cancer. वहां पर भी biopsy नहीं थी. वहां पर हमने intraoperative frozen करके decide किया whether to do thyroidectomy or not. Here also, whether to do orchidectomy or not is going to be done intraoperative. So you are doing a intraoperative frozen section if there is a doubt. If there is no doubt, you can straight away remove it. If you see it looks like a cancer, you can straight away do the orchidectomy. If you feel there is a doubt, take a piece, do frozen. But the main thing is your piece, your biopsy is coming from here, not from here. You are not cutting the scrotum because you don't want to spread the cancer from testes to scrotum. So you are sparing the scrotum. So this is what you are going to do. What do you do after this? After high inguinal orchidectomy, after this, you will do PET scan. So your staging is after surgery. So your TNM staging comes here. Okay, after orchidectomy. So हमने अभी तक कोई भी कैंसर में नहीं किया, right? So now you come to know, are there metastasis, nodal metastasis, lung mets वगैरह वगैरह, ये सब आपने अभी बाद में देखा है. You have already done the orchidectomy. Post orchidectomy you are doing this. So based on this, you will come to know the TNM stage, stage 1, stage 2, stage 3, stage 4. Now luckily for us, there are only 3 stages in testicular cancer. So I am giving you stage-wise treatment. And there are only 3 stages. There is stage 1, there is stage 2, and there is stage 3. Stage 1 means no metastasis. Stage 2 means lymph node metastasis. And stage 3 means distant metastasis. There is no stage 4. And you don't need to know exact T1, T2, T3, T4, not required. Only this much is needed. If the tumor is a seminoma, or it is some other tumor, non-seminomatous germ cell tumor. Seminoma in me, NSGCT in you, because you will get a teratoma. You will not get a seminoma yet. What do you do next? If there is no metastasis for seminoma and no metastasis for teratoma, क्या करोगे next? कैसे हमने सारे सर्जरीज सारे कैंसर्स किए हैं stage wise. So for seminoma, you have 2 choices. Either you can give single chemotherapy, means 1 cycle of chemo, or you can give radiotherapy, because seminomas are radiosensitive. No other testicular tumor is radiosensitive except seminoma. Here you can't give radiotherapy, so here you will give only 1 cycle of chemotherapy. Okay, so for stage 1, you can choose for teratoma chemo or seminoma either. Either of them are okay. बस इतना ही करना है. For all the other stages, whether it's seminoma or other tumors, if it's stage 2 or stage 3, you will give chemotherapy. Okay, so तीनों में stage 2 हो या stage 3 हो, seminoma हो या non-seminomatous हो, stage 2, stage 3, only chemotherapy, right? And the chemotherapy that you give is called as BEP. This is not a benign enlargement of prostate. Just tell me what is the P. Only P is important. And you will be happy to see what is P. What is P? Yeah, the drug you have been using all along, platinum. Okay, BE जानने की जरूरत नहीं है. Bleomycin etoposide, you can write it if you want. ये काम का नहीं है. ठीक है? So you will give chemotherapy for stage 2, stage 3 testicular tumors, irrespective of the type. Sometimes, if the person has para-aortic nodes after chemotherapy, so para-aortic nodes, if they remain post chemotherapy, मतलब आपने chemotherapy दे दी, but still person has some para-aortic nodes, they have to be removed by a procedure which is called as RPLNP, retroperitoneal lymph node dissection. Okay, but this is rarely required आज के ज़माने में. आज के ज़माने में chemotherapy will take care of everything. But if there are lymph nodes remaining, so para-aortic lymph nodes remain after chemotherapy, you have to go inside and remove them surgically. That is called retroperitoneal lymph node dissection. ठीक है? आ गई बात समझ में? So that will complete most of the IMP topics of urology. Now we are left with plastic surgery, burns, and general surgery. Interesting topics and not very difficult. So we can cover a lot of these topics today, hopefully. The first thing you have to understand here about burns is that burns is not I got burnt here and that is the end of the story. Okay, हमारे मन में क्या होता है, यहाँ बर्न हुआ, यहाँ बर्न हुआ, यहाँ बर्न हुआ. That is just one part of the disease. That is the local effect of the burns. But mind you, if I get burns over a large area, 10%, 20%, 30% burns, then apart from the skin, my body also gets affected. That is called as systemic effects. Okay, so अगर आपके घर में किसी को चटका लगे या इलेक्ट्रिक शॉक लगे, in that case, you are not going to just think कि चलो यहाँ skin burn हो गई. You are going to think, oh, there may be some systemic effects, and I'll tell you what they are. So you go 2 steps, 1 step at a time. First step is local effects. So जहाँ पर भी चटका लगा सबसे ज्यादा, so there will be some high heat in that area. Because of the heat, the tissue gets burnt. So whatever gets burnt, that is the central core, that is called zone of coagulation. Zone of coagulation is the central zone that tissue is going to die. It's either going to die or it is already dead. That cannot be saved in the central zone, जहाँ सबसे ज़्यादा heat थी. But what happens gradually, as the heat will pass from the site towards the periphery, it becomes a little cooler. It cools down a bit. So maybe here it is say 100 degrees. Here it will be maybe 80 degrees. By the time it reaches the surface, periphery, it will be 40, 50 degrees. So heat also gets dissipated. So the area adjacent to the zone of coagulation is called zone of stasis. This zone is what we call as the at-risk zone. At risk means if I don't do any protective measures, this zone will also become ischemic. So this is the at-risk zone, zone of stasis. And the third zone is the outermost zone, that is the zone of hyperemia. That zone will recover. It is a safe zone. So basically, if I get burnt, whatever measures I take is to basically protect the zone of stasis. Because zone of coagulation is gone. I cannot save it. Zone of hyperemia will recover by itself. Nothing needs to be done. It is zone of stasis and I can save this. Something similar happens in stroke. Have you studied stroke? Ischemic stroke? Ischemic stroke में क्या होता है? इससे सुना है कभी? There is one central area which is dead and there is a peripheral area just around the ischemic area which is called ischemic penumbra. So किसी को stroke होता है ना, तो whatever you do, thrombolysis, it is to save the area around. That is called the penumbra. So same way over here, you are trying to save the zone of stasis. The core is gone, you cannot save it. The periphery can be saved, right? That is the message. So the local effects are based on these three zones. But I told you there are systemic effects. Systemic effects means what? If the burns area is very large, so if the percentage of total burn surface area is large, large means more than 15% in an adult. इतनी सारी skin burn हो गई 15% से ज़्यादा. Why do we have skin? What is the purpose of our skin? Skin का क्या role है? It is the largest organ in the body. करती क्या है वो? Protection from what? Protection from what? What is it protection? No, not infection. One of the functions is of the skin is it will keep my tissue fluid in the body. Underneath the skin is my subcutaneous tissue, muscles and all. So all of them have tissue fluid. When I lose the skin, those tissue fluids are exposed. And because of that, the tissue fluid can get evaporated. तो जहां पर भी बर्न होती है ना और स्किन चलेगी, अंदर का जो भी एक्सपोज चीजें हैं वो सब इवेपोरेट हो जाएगा. ऑल द फ्लूइड, द इंटरस्टिशियल फ्लूइड विल बी इवेपोरेटेड. सो if the burn surface area is very large, more than 15%, you can have massive fluid depletion. And this can lead to hypovolemia. I am telling you this for a reason. When you are going to study resuscitation of patient in burns, you know you are going to use some formulae. When we actually apply the formula, it leads to a lot of fluid. Why are you giving so much fluid? Because the person will become hypovolemic, which is unusual otherwise. Too much hypovolemia again. That is one problem. Other problem is you have so many burns in so many areas of the skin. You are saying defense. That defensive barrier is gone. So there is an increased risk of infection. Because of infection, person can become septic. So there can be sepsis. And because of sepsis, remember pancreatic necrosis, sepsis, organ failure. So the person can end up with organ failure, any kind of organ failure, renal failure, ARDS, encephalopathy, paralytic ileus, वगैरह. It is there in RR notes in the end. Burns and plastic surgery are the last two modules, transplant के बाद. So it can lead to organ failure. And this is the most common cause of delayed death after burns. So why does a person with burns, 50%, 60% burns die? It's because of septicemia after a few days or weeks. He will get pseudomonas infections because there are so much burns and he will die because of septicemia. And the third thing that can happen, which is seen in some types of burns, are inhalational injuries. You can get inhalational injuries. This happens because of inhaling hot fumes. When will the person have inhalational burns? कैसे पता चलेगा? कौन से पेशेंट में होंगे inhalational burns? घर में किचन में चटका लगा उससे inhalational burn तो नहीं होंगे. Inhalational burns कब होते हैं? Normally steam, soot. This happens normally if a person is stuck in a closed space. Like the house caught fire, the house is burning and you are not able to escape because the door and everything is on fire and you are stuck in a closed space. इसमें क्या होगा? This will cause inhalational burns. So inhalational burns means your nasal mucosa will get burnt. So your nasal hair gets burnt. Face can get burnt. This will all tell you that, okay, he has inhalational injury. Or there can be laryngeal edema. Because garam fumes inhale kar liye, larynx can get burnt. So there can be laryngeal edema. And this can kill the patient. There can be CO poisoning, carbon monoxide poisoning. This is the most common cause of immediate death in burns. तो अगर बर्न सीन पे कोई मर जाता है ना, इट्स नॉर्मली बिकॉज ऑफ कार्बन मोनोऑक्साइड पॉइजनिंग. यू हैव सीन इन ओल्ड हिंदी मूवीज दैट बाय द टाइम द hero tries to rescue the heroine, When he reaches inside, she's already unconscious. That's because of CO2 poisoning. And then he carries her and jumps out of the building. So why is she unconscious? It's because of CO poisoning, carbon monoxide poisoning. Right? So itna sab ho sakta hai burns. He can become hypovolemic, he can get septicemia, he can get inhalational burns. So burns is a disease with systemic problems. It is not just यहाँ पे चटका लगा बस हो गया. अभी ठीक है, हर पेशेंट को तो ये प्रॉब्लम नहीं होने वाला. कौन से पेशेंट में ये प्रॉब्लम्स होंगे एंड विच पेशेंट्स शुड बी एडमिटेड. क्राइटेरिया फॉर एडमिशन. इसमें एमसीक्यू आते हैं. कौन से पेशेंट को आप एडमिट करोगे. सबसे पहले तो इट्स बेस्ड ऑन द टोटल बर्न सरफेस एरिया. If it is more than 10%, ये न्यू अपडेट है. दिस इज गिवन इन ATLS जो हम कर रहे थे ना कल, ट्रॉमा उसमें दिया है. more than 10% in an adult or even a child, they should be admitted. अगर आप बेली पढ़ोगे ना उसमें थोड़ा अलग है, पर आप लोग बेली नहीं पढ़ने वाले, मुझे पता है. So 10% बर्न से भी ज्यादा हुआ ना, you will admit the patient. Or if he has any amount of full thickness burns. What is full thickness burns? I will tell you. जिनको हम deep burns या third degree burns बोलते हैं. Any full thickness burns, even if it is 1%, he should be admitted. Full thickness burns ना ऐसे ही किसी को नहीं होते. You require a very severe burn injury to get a full thickness burn. तो full thickness burn में मतलब कुछ तो गड़बड़ है, इस पेशेंट को भर्ती करना पड़ेगा. Then there are some other important features, like if the patient is having burns in a dangerous area, dangerous body part, like if he has burns over face, or if he has burns over genitalia. Don't ask me why. Or if he has burns over palms and soles. These type of burns are associated with a lot of complications, so they should be admitted. Or if the mechanism of burns is dangerous, like person got electrical burns, shock laga or burn ho gaya. Or if he got chemical burns, very important. Chemical burns, this happens in factories where there are chemicals. He got electrical burns, chemical burns, or if you suspect he is having inhalational burns, तो उनको आपको भर्ती करना पड़ेगा. If you read the books, they give many criteria, but this is a very easy way to remember, right? Now, patient comes with burns. You are thinking of admitting him. First, you have to assess and you have to stabilize. So, how are you going to stabilize? Just like you did in ATLS, something like ATLS. So, first you will check his airway, breathing, circulation, disability. Okay, ABCD करेंगे. Then your E, exposure, is going to be this assessment, because I want to know extent of burns and I want to know depth of burns. कि भैया 5% है, 10% है, 20% है, फर्स्ट डिग्री है, सेकंड डिग्री है, थर्ड डिग्री है, तो ये सब मुझे देखना है. तो आई विल डू ABCD, airway, breathing, circulation, disability, exposure, to come to know extent of burns. ये क्या है? What is this? The first image. You said your FMT is done, right? So you should tell me how are burns assessed. ये रूल ऑफ 9 है. मेरे को तो 9 नहीं दिख रहा, यहाँ 13 लिखा है, यहाँ पे 2, 1.5. ये कौन सा रूल ऑफ 9 है? तुम लोग ना कुछ भी मेरे को टिकाओ मत, जो दिख रहा है वो बताओ. ये कौन सा वॉलिस रूल ऑफ 9 है? 9 कहाँ लिखा है इसमें? एक जगह दिखा दो जहां पर 9 लिखा है, बस फेंकने आ जाते हो. दिस इज कॉल्ड Lund and Browder's chart. Okay, Lund and Browder's chart. This chart is something that is useful for calculating burns in children. बच्चों में यूज करते हैं, क्योंकि ये क्या करता है, based on the age, it tells you the different percentages of every body part. So it will tell you that, okay, if the child is 1 year old, then his head in a 1 year old child is going to be only 8.5%. But if the child is 10 years old, then the head will be 5.5%. So it will change head, thigh, leg for every child based on his age. For adults, you can use your favorite Wallace's rule. एडल्ट है तो आप वॉलिस टिका दो, कोई बात नहीं, एग्जाम में पूछते भी है वॉलिस's रूल, फोरेंसिक में पढ़ाया होगा. बट इफ अ पर्सन हैज अभी पूरा आग नहीं जला है, दो तीन जगहों पर इट हैज बर्न, देन व्हाट विल यू डू? देन यू कांट यूज ना. फुल आर्म इज 9%, बट इफ ही इज हैविंग सम एरियाज व्हिच आर बर्न्ड, तो क्या करेंगे? सो इफ देयर आर पैचेस ऑफ बर्न्स, then what you do is you use the palm rule. Palm rule means the size of the patient's hand is 1%. So the patient's hand, patient ka hand means palm and fingers put together, is about 1%. So what you will do is patient ke haath ke size ka you will cut a piece of cardboard that becomes 1%. Wherever he has burns, you attach that and see kitne karke it is getting added. So hand, or basically palm plus fingers, is 1% in an adult. Okay, that is called rule of hand or rule of. So as you come to know kitne percent burns hai, so let's say patient has, for example, 30%. Now I want to know 30% burns hai, par kis prakar ke depth of burns. So I want to know, is it first degree, second degree, or third degree? This is more important because deeper burns are obviously more scary. They will cause more complications. So when I look at the depth of burns, what are all these types? When I see the skin has two parts. Skin में दो parts होते हैं. Okay, the upper part, this part, is the epidermis, and then I have the dermis. Dermis has two parts. There is a papillary dermis. There is a reticular dermis. And uske niche is the subcutaneous tissue. There will be subcutaneous tissue, subcutaneous fat. Right. So my skin has mainly two layers: epidermis, dermis. Dermis is much bigger. It has two subparts: papillary dermis, reticular dermis. When I say first degree burns is only in the epidermis. Sirf itna burn ho, epidermal burns, which you get like if you go to if you are out in the sun for a long time, you go to those what are they called, water parks, जहाँ पर धूप में आप पूरा दिन स्विमिंग कर रहे हो. So then you get burns over here on your shoulders. बीच में मुझे पता नहीं कौन जाता है, बीच पे तो आप बर्न नहीं होते होंगे. I don't think so. Tan, maybe not in India. Maybe you must be doing it in China with the pandas or the other places. India में कोई नहीं करता. India में आप water park जाओ and you get burns over here, shoulder पे, forehead पे. Those are sun burns. Those are first degree. So no problem there. Second degree burns involve epidermis and some parts of dermis. So second degree burns are partial thickness. So you can have a second degree superficial partial thickness. You can have a second degree deep partial thickness. Means superficial partial means it involves epidermis and papillary dermis maybe. Second degree superficial, papillary dermis. Second degree deep will have some amount of reticular dermis. Partly. Reticular dermis, some part. And third degree are full thickness. Full thickness means pura epidermis and full dermis. That is third degree. Right. So like this, you have these three grades of burns: epidermal burns, partial thickness burns, which can be superficial or deep, and third degree or full thickness burns. ये तो सब माइक्रोस्कोपिक लेवल पे. एक की कैसे पता चलेगा whether it is first degree, second degree, third degree? How do you know? So I'll tell you very simple way. First degree epidermal burns, they are going to be red. They are going to appear dry. They will be very painful. So अगर आपको sunburn होगा, you know it burns a lot the next day, but they are absolutely dry. So red and dry, painful, and they have no scarring. So they will heal absolutely all right. Within 5 to 7 days, it will be gone. नामो निशान नहीं होगा because it is only epidermal. So epidermal burns काफी जगहों पर they are not even taken as burns. They are taken as okay चलो mild injury. उसको burns गिनते भी नहीं. Second degree partial thickness, ये बहुत काम किया. Superficial partial thickness. They have very typical color. They are going to be, they will be moist, and they show something called as a blister. They are also very painful. They will also heal without scarring. They heal all right. They take about 3 weeks to heal. Little longer, but scar नहीं होगा. जो घर में आपको गर्म पानी से बर्न होते हैं ना, those are these second degree partial thickness. कभी उस पर गोला बन जाता है, you get a bleb. That is this blister. Second degree partial thickness. Domestic burns are these. You burn yourself with a hot iron, you will get this. Try करके देख लो. The more dangerous ones are second degree deep or deep partial thickness. These will appear white. They will have an appearance which is called mottled. Mottled is something that you see even in people who are dead, because the skin is dead. They will be painless and they will heal with a bad scar which is called hypertrophic scarring. So they are not going to heal well. So second degree deep burns, not so good. They have a mottled look. That skin is properly dead. वो नहीं बचने वाला. तो उसकी scar भी बहुत ही गंदी, बहुत ही ugly होगी. And the last one, full thickness burns. They appear black. They will be charred. So black and charred. They will have no sensation, and they will heal with a special type of scarring. It is called eschar. So there will be eschar formation. It's a very thick scar. It is called eschar. And this eschar causes a constriction. वो ना धीरे धीरे it keeps getting tighter, right? So it will be eschar formation. Like this, just looking at it, you can predict what is the depth of the burns. So now you tell me depth of burns. What is this? The first image. What is this? What type of burn is this? Yeah, this will be first degree because it is dry, absolutely dry, and it is pinkish red. Second degree, what is this? So this is going to be second degree superficial or superficial partial thickness, because you see pink and moist. What is this? ये क्या दिख रहा है? This is going to be third degree because this is all black and charred. थोड़ा थोड़ा बीच में there is second degree also. It's a mixed burns, but mainly the important part is third degree. Okay. बीच में there is a mixed burns. What I'm trying to tell you is third degree burns ना कभी isolation में नहीं हो. They require a very grave injury. This will happen in industrial burns or factory में होगा. Electrocution, lightning, उसमें ऐसे burns. घर में गर्म पानी से चटके से ये सब नहीं होगा, उससे ये हो. Okay, so with common sense also you can get an idea of the depth of burns. You don't have to be very gung-ho about it. Now you know patient has burns. How much fluid do I have to use in resuscitation? This can come in your exam. Fluid for resuscitation. How much fluid to give? For how long? So there are two formulae you should know. The first formula is the Parkland equation. What this tells you is the amount of fluid I will give in the first 24 hours is given by the formula 4 ml into body weight in kilograms into total percentage burn surface area. Okay. For example, if the person, let's say, is 40 kgs and the burn surface area is 50%. So I will give him in the first 24 hours 4 into 40 into 50. So this becomes about 8 liters, 8,000. इतना फ्लूइड मुझे उसको देना है in the first 24 hours. 8 liters. 8 liters is a lot of fluid. 8 liters बहुत हो गया. नॉर्मल इंसान को 2.5 लीटर फ्लूइड देते हैं, इसको हम 8 लीटर्स दे रहे हैं. सो इमेजिन हाउ मच यू आर गिविंग. But this full fluid I am not going to give all at once. I will divide it into two halves. Half I will give in 8 hours, which means 4 liters in 8 hours. The remaining 4 liters I will give in 16 hours. And the fluid that I am going to give is going to be Ringer lactate. All right. So you have so many possible questions that can come on this alone. RL देंगे, आधा देंगे पहले 8 hours में, बाकी का आधा you will give in the next 16 hours. So it's not that 12 hours. It is 8 hours and 16 hours. First you want to resuscitate more. Then you will slow down a bit. But they realize this is too much. ये बहुत aggressive है. So the formula which is currently used is ATLS formula. And this formula says in the first 24 hours, if the person is an adult, more than 14 years, you are going to give not 4 ml, you will give 2 ml into body weight into percentage burn surface area. So it's practically half of this. So अगर 14 years से ऊपर है, you will give 2 ml. If it's a child who is less than 14 years, then you will give 3 ml into body weight into burn surface area. आया बात समझ में? So the formula which is followed currently is the ATLS formula. But what they also say is you have to keep a target. That am I giving him enough fluids? Am I giving him too much? Because this is all arbitrary. So the target is the urine output should be 0.5 ml per kg per hour. Okay. ये fluid urine output के हिसाब से मैं उसको fluid दूंगा. Right? They will obviously specify which formula to use. So for an adult, this will be your target urine. For a child, it will be 1 ml per kg per hour. If it's a child. Right? So these are the formulae that you need to know. If they ask you which one to use, you should be ready. It's very standard, but more importantly, remember the fluid that you're going to use is going to be Ringer lactate. And all these formulas are 24-hour based formulae, and the ration is going to be half in 8 hours, balance half in 16 hours. In both the formula, it is the same. Baki ka sab same. Right? Apart from this, you have to do some more things, like you have to give the person IV antibiotics. You have to give him IV analgesics. इतना सारा burn हुआ है तो ये सब देंगे आप. For nutrition, you can give him nasogastric feeds. If he is not able to take orally, you can give nasogastric feeds. And you have to look after his wound. So for wound, you will apply some antimicrobials. The most commonly used is silver sulfatazine. It is anti-pseudomonas. So ये आप लगाएंगे silver sulfatazine. Anti-pseudomonas. It is one of the most commonly used antimicrobials. Urine output child में ज़्यादा होना चाहिए. Okay, child में ज़्यादा होना चाहिए. होगा नहीं, होना चाहिए. This is your target. You can use silver nitrate, but there is a problem with this. It stains your furniture. It stains the clothes. So it is avoided. It's a painful cream. Patient को दुखता है ये लगाने से. It burns. And there is a cream which is called mefenide acetate commonly used in abroad, not very commonly used in India. It can lead to metabolic acidosis. तो अगर ये आपने बहुत ज्यादा लगा दिया ना पेशेंट को, he may get acidosis. Why does he get acidosis? क्रीम से acidosis कैसे होगा? Ketamine has written it, met acid. Why but? M for mafenide, M for metabolic acidosis. No, not because of penetration, it's because of acetate. The acetate will give him acidosis. Okay, that's how you should remember. That is the fundamental behind it, right? So, ऐसा करके you are going to manage a patient with burns. We have done it comprehensively, each and every step along the way. Now we go to plastic surgery, which is a beautiful concept to understand. What does a plastic surgeon do, really speaking? When I say plastic surgery, what does it mean? Plastic surgeon करता क्या है? Compartment syndrome is orthopedic. Surgery में normally होता नहीं. Normally होता नहीं. Yeah, plastic surgeon will do plastic surgery. Nice answer. When I say plastic surgeon, what he's actually going to do, they don't call themselves as plastic surgeon. They call themselves as reconstructive surgeons. So what the role of a plastic surgeon is to reconstruct defects, wounds, and so on and so forth. Right? So if I underwent MRM and I want to get a new breast, I can get breast implants, or I can get some flaps, some tissue from the vicinity, plastic surgery. If I have too much fat on the belly, abdominal wall fat, and I wanted the fat to be removed, abdominoplasty, liposuction, plastic surgery. Men with gynecomastia, they can undergo liposuction for gynecomastia, plastic surgery. So what they are doing, they are reconstructing for better function and better cosmetics. But function bhi milta hai usse. If I have an ulcer which is not healing and I put some cover on it to make it heal, plastic surgery. We studied something day before yesterday. No, I don't do this. Pediatric is very different. Very, very different. So we studied something, oral cavity. You have a cancer, you do a wide local excision here. So there is a big hole over here. Fill it with something, plastic surgeon. Right? So plastic surgeon has a lot of tools to fill in the gaps. What are these tools? It's called the plastic toolkit. पहले इसको बोलते थे reconstructive ladder. The simplest tools that he have are suturing. This is the simplest. If you go a little more complex, he can use grafts. What are grafts? I will tell you. If grafts are not good enough, he will use flaps. And right at the top, the most advanced is what is called as a free flap. So if I go from simple to advanced, this is a sequence. So to label someone as a plastic surgeon or a reconstructive surgeon, he should be able to do a free flap. If he can do a free flap, he can do anything in plastic surgery. So plastic surgeon ka goal, highest ambition is to be able to do a free flap. Right? But it does not mean that every wound will require a free flap. Smaller wounds, different wounds can be filled with different things. That's what you need to understand. So अगर छोटा मोटा कट हो गया आपको यहाँ पे हो गया and you undergo suturing or stapling, that is a low level. But sometimes the gap is a little big and you can't do suturing because there is a gap. It's not going to get sutured. One option is a graft. What is a graft? Graft is a island of tissue. So it's a piece of tissue which doesn't have blood supply. So it is without its blood supply. Okay, don't talk about organ transplant wale grafts. Huh? Those are different. ये वो वाला नहीं है. This is not kidney transplant wala graft. This is graft in the same person for tissue reconstruction. So these are reconstructive grafts. They don't have their own blood supply. So they get blood supply from the wound. So जहाँ पर भी जख्म है वहाँ से उसको blood supply मिल जाएगी. So there are different types. You have skin grafts. which are the commonest ones, जिसमें you have split thickness or partial thickness skin graft. Then you have full thickness skin graft. And then you have something called as composite skin graft. Composite means you are taking skin and some other structures like some fat, subcute fat, that becomes composite. कुछ extra चीज ले लिया skin के साथ. In orthopedics, you will study nerve grafts. You will study tendon grafts. So these are some of the commonly used grafts. They are used more in orthopedics. Nerve injury हो गई तो nerve graft डाल दो. Tendon repair tendon. So these are some of the grafts which are available. Now we will study the skin grafts because that is what they ask in the exam. The first type is the split thickness or partial thickness. It's also called as Thiersch's graft. Where did you hear the word Thiersch before? Anywhere else you have heard the word Thiersch before? Thiersch पहले कहीं सुना है? Anal, anal क्या? Ortho only motivation. इसका क्या मतलब हुआ? Yeah, in rectal prolapse, one of the perianal surgeries was anal wiring. Thiersch's anal wiring. This means you just take a stitch at the anal canal. Same insan, he also did this. That is Thiersch's split thickness skin graft. So what is the split thickness skin graft? Where the graft that you take contains epidermis and some dermis. तो पूरा dermis नहीं लिया मैंने, epidermis and some dermis. For example, I got a burn on my chest and now there is a wound on the chest because the burn wound was not healing. Or I have a small ulcer, which is a little big. Means it's big enough for me not to be able to suture it. I want to put some cover. I can take some partial thickness skin from my thigh and put it on the chest wound. So it will give a cover to the chest wound. That is a split thickness skin. Split thickness skin graft is used mainly where you have large superficial wounds. So if it's a large but a superficial wound, you can use a split thickness skin graft. Large superficial wounds, जैसे बहुत सारे जगह पे burns हो गए, अब सब जगह जख्म है, cover करना है split thickness skin. Where do I not use a split thickness skin graft? What is the main contraindication? There are two. The first is, please understand, grafts require blood supply from the recipient site. जहाँ पे आप डालोगे वहां से blood मिलेगी. So the area, the recipient bed, should have good vascularity. So if the recipient bed is poor in vascularity, this is normally seen where there is an exposed bone or exposed tendon. These are areas where the blood supply will be poor. उसपे skin graft नहीं डाल सकते क्योंकि उसको blood supply मिलेगी नहीं, graft बचेगा नहीं. And the second thing is, this has poor cosmesis, so it cannot be used in area where cosmesis is needed. Because these grafts, they look very ugly. So if I have a wound on the face, I can't put a split thickness because these grafts undergo what is called as secondary contracture. तो अच्छे नहीं दिखते हैं. अगर आप में से किसी ने split thickness skin graft किया है अपने ऊपर, you will know what I'm talking about. अगर आपने किसी patient पे किया है, you see his area where you have put the graft, the recipient side. It's not going to look normal because they undergo some contraction. तो जहाँ cosmesis है वहाँ नहीं कर सकते. Now how do I harvest it? I harvest it using this or using this. What is this first image? This is skin graft, split thickness graft harvest करते हैं. This is called Humvee knife. Very good. This device, this is called a dermatome. It's a machine. ये आपको split thickness graft काट के देगी. After you remove the graft from wherever, you have to puncture it like this. You have to mesh it so that it gets a little stretched. Size बढ़ जाती है. So the graft after harvesting has to be meshed. From where do I harvest it? Sites of harvest. Normally from the thigh, but I can also take from the abdominal wall or from the back. ज्यादा चाहिए तो वहां से भी ले सकते हो, या अगर जख्म थाई पे है तो आप चेस्ट से एब्डोमिनल वॉल से ले सकते हो. इट्स वेरी सिंपल. Wherever the wound is, उससे थोड़े छोटे साइज का you take skin graft from some other site, mesh it, make some holes in it, stretch it, put it on the recipient site and stitch it. So yeah, right. There is nothing like commonly used of breast. Normally you take it from thigh, but there is no rule as such. It depends on your how much you need. So this is split thickness, partial thickness, epidermis and subdermis. Now if I have a small wound on the face, छोटा सा wound, where I can't put a split thickness skin graft, I can put a full thickness skin. This is also called as Wolff's graft. Here the graft contains epidermis plus entire dermis. So it contains epidermis plus entire dermis. This is going to be kept in areas where the wound should be small because you don't get too much of full thickness skin. कहाँ से लोगे? जहाँ से भी आप पूरी skin काटोगे वहां पर नया जख्म बन जाएगा. So it can only be used for small wounds where cosmesis is needed. So best area is face. तो फेस पे छोटा मोटा जख्म हो गया, फुल थिकनेस ग्राफ्ट लगा सकते हैं. दे हैव अ गुड कॉस्मेटिक आउटकम. ओनली थिंग इज they cannot be placed in areas of poor vascularity, same because this is a graft. So wherever the vascularity is poor, you cannot put it. This is going to be harvested not with a Humvee knife. This will be harvested by the surgeon with scissors. So he has to cut the full skin from wherever he is taking. So this will be harvested with scissors or knife. From where do I harvest it? Full thickness skin मैं कहाँ से लूंगा? थाई से नहीं ले सकता, थाई पे जख्म हो जाएगा. Why post-auricular, supraclavicular? Why these areas? Abdomen बोल रहा है अनमोल और गुलाम मुस्तफा. Soft, thin skin, कुछ भी. If you want excess skin, groin is the best area. Groin, abdomen, हम सबके पेट बाहर है. Abdomen पे बहुत चमड़ी है, वहां से ले लो full thickness. So no. If you want to put on the face, you want skin which mimics the skin of the face. So you take it from post-auricular or supraclavicular fossa because these areas are relatively hairless. You want areas which are hairless and they look a bit like the skin of the face. I cannot use the skin of my abdomen. Men have so much hair on the abdomen. If I take skin from there and put on my face, वहां से बाल निकलने लगेंगे and they will not match my beard because that's a different texture of hair. So it will look very unsightly. On one hand, you are saying cosmesis. On the other hand, you are taking groin skin. क्या cosmesis? बात समझ में आई? ये फंडे हैं जो आपको समझ में आने चाहिए. This will give you so much clarity when you study these kind of topics, right? इसीलिए नीचे के बाल यहाँ मत लगा. प्लीज ऐसे कारनामे मत करना. भले प्लास्टिक सर्जन मत बनो लेकिन ये सब चीज मत करना. फेस पे लगाना है, कान के पीछे, शोल्डर से, गुड स्किन, राइट? सो दैट इज अबाउट फुल थिकनेस ग्राफ्ट. ओके, आंसर दिस. खुश हो जाते हो, मैं कुछ भी ना थोड़ी वल्गर चीज बोलता हूँ ना, इतना खुश हो जाते हो. तो स्प्लिट skin graft is epidermis and partial dermis. Epidermis and deep dermis or full dermis is going to be full thickness graft. What is this? Epidermis, dermis and subcutaneous fat. Last one again. What is the last one? Epidermis, dermis and subcutaneous fat. Flap. No, this is called composite graft. Flap तो किए नहीं अभी तक. It's called composite graft. ठीक है, ये जो मैंने बताया आपको. Okay. Now come to flaps. Flap करना किसी के भी बस की बात नहीं. फ्लैप करने के लिए you have to be a plastic surgeon. स्प्लिट थिकनेस ग्राफ्ट तो मैं भी कर सकता हूँ. स्प्लिट थिकनेस, फुल थिकनेस, आई डोंट नीड टू मच एक्सपर्टीज. फ्लैप्स I cannot do. Flaps is done by someone who's a true reconstructive surgeon. So what are these flaps? Flaps are tissues with their own blood supply. So they carry their own blood supply, which means I can put flaps in areas where the blood supply is poor. Like there is a bed sore. Bed sore में blood supply बहुत कम होती है. If I want to cover it, I can put a flap. Big wound on the face. Bone is exposed. Tendons are exposed. So head and neck cancer is flap, not graft. Because blood supply is not so good. So you need something with its own blood supply. There are many types of flaps. The important types that you need to know are based on how far they are, their distance. So you have local flaps and you have distant flaps. ये सबसे important. And distant में you have pedicle flaps and free flaps. ये हम पढ़ेंगे. I told you ना, free flaps most advanced. The certification of a plastic surgeon is a free flap. Not everybody can do it. Free flap is the best flap. So these are some of the flaps. We will discuss them. And you can also identify the flap based on the content. That what is the flap made up of? For example, if the flap contains only skin and subcutaneous fat. Flap, a flap, not graft. Flap, which means it is having blood supply. It contains skin and subcutaneous fat. It is called a cutaneous flap. If it contains skin, subcutaneous fat, and some muscle also, then I will call it a myocutaneous flap. If it contains bone also, osteomyocutaneous flap. So like this, the tissue that I take, what all it contains will be the type of the flap also. ठीक है, आया सब समझ में? तो ऐसे अलग अलग प्रकार के फ्लैप्स होते हैं जो मैं आपको बताऊंगा. एग्जाम में क्या पूछेंगे वो भी बताऊंगा. ग्राफ्ट कभी पेडिकल नहीं होता. अगर इट्स लाइक अ पेडिकल ग्राफ्ट, ओके ठीक है. So now understand what are local flaps. These are flaps for filling wounds in the vicinity. Vicinity. For example, person has a pilonidal sinus. Pilonidal sinus, ये जो gluteal cleft होती है ना, उसके ऊपर एक sinus होती है यहाँ. It happens in young hairy men. If there is a sinus here and I excise it, so there will be a wound over here. It is just above my gluteal cleft. उसके just ऊपर, जहाँ पर tailbone होती है ना, वहाँ पर होता है. So I have excised it and there is a hole over here, a big hole. To fill this hole, I take tissue from the vicinity. I take it, cut it around. So when I cut it here, here and here. I don't cut it here. Because the blood supply is coming from here. This is from where the blood supply is coming. So I turn it around and put it over here. So the blood supply will continue to go to the flap. So the flap is carrying its own blood supply. That's why it's a flap. Blood supply continuity. This type of a flap is called a rhomboid flap. Also called a Limburg flap. It is used for pilonidal sinus. Similarly, sometimes what happens is you have an accident. भाजी काट रहे हो बड़े knife के साथ, and the chip of your finger gets cut. It gets avulsed, as you see in the image. तो आपको इमेज में दिख रहा है कि उंगली की चिप चली गई है. फ्लैप जहां से निकाला वो तो ये छोटी सी वुंड है. You will suture it. Obviously, you will only take as much tissue as the original site can tolerate. इतना ज्यादा नहीं ले सकते कि ओरिजिनल साइट पे बड़ा होल हो गया, वो नहीं चलेगा. वरना कोई भी कर ले ना. Otherwise, you and me can also do the surgery. This has to be done by a plastic surgeon because you have to calculate कि बॉस इतना बड़ा वुंड है तो बगल से मैं इतना टिश्यू लूंगा, उसको मैं टर्न करूंगा तो बगल वाली जगह में भर जाएगा and the gap won't be too much. So this requires calculations, measurements. to fill the gap without creating a new gap. वरना यहां से निकाला, वहां पे लगा दिया और वहां पे नया छेद हो गया. So it is obtained from the vicinity. So if the hole is over here, the defect is here, I take the skin flap from here, from the vicinity. That's why local, in vicinity. If the finger chip tears, what I do is I take some tissue from the adjacent area from here, advance it and fill the gap as you see in this. This is called a advancement flap. So I have just advanced the tissue from the vicinity to cover the hole, to cover the defect. So बगल की skin को, tissue को I will cut. I am not disconnecting it because the blood supply is going to come from here only. So I am not cutting it apart. I am just cutting it from the sides, keeping the blood supply intact, pulling it on top and suturing it. So the blood supply will continue to come from the side like this. This is called an advancement flap. ऐसे you have different types of local flaps. This is rhomboid flap, advancement flap. This is the flap used in lip cancers. This is called Abbey flap. It is used for lip cancer. Like I remove the cancer from the upper lip. There is a hole in the upper lip. I take a flap from the lower lip and put it to the upper lip. So lower lip, which is more bulky, you can take some tissue. Lower lip is bulky, you can take some tissue, fill the gap in the upper lip. हो गया काम. But blood supply is intact. Its blood supply is going like this. So when I turn it around, blood supply will continue to go like this. This is a Abbey flap. ऐसे you have local flaps. Simple. आसपास की टिश्यू को लगा दो, डिस्कनेक्ट मत करो. There is no disconnection. It is in continuity. On the other hand, local flaps, फिर लिप कैसे खुलेगा? After some days you have to disconnect. एक बार इसको यहाँ पर टेक हो गया ना, then you disconnect. So 8 to 10 days later, it requires 2 steps. It's a 2-stage procedure. In the second stage, you are going to disconnect. So for 8-10 days, lip will be closed. वो straw से पानी पिएगा, straw से खाएगा, बाद में उसको कट करना है. बच्चों में लिप कैंसर होनी तो नहीं चाहिए कायदे से. Now we talk about distant flaps. Distant flap means where the defect is and from where you are harvesting, they are not in continuity. So either you take pedicle flaps or you have free flaps. In pedicle flaps, like for example, I will give you an example you will understand. Let's say there is an oral cancer which I have resected. I take tissue from the shoulder. Okay, so skin and subcut from the shoulder is taken. It is taken to the face, and the blood supply for this area which was supplying here, now the blood supply will come like this. So I've taken tissue from the shoulder and put it on the face, but the blood supply is in continuity. This is a pedicle flap. But they are two different areas. Shoulder to face. It's not only face to face. It is from shoulder taking it to face. But the pedicle is attached. So this is a pedicle flap. This type of a flap, the one that I described, it's called the deltopectoral flap. It's a type of a pedicle flap. That I took skin subcut from the shoulder and chest, put it here with the vascular pedicle in continuity. Pedicle means where the blood supply is coming from. Why don't they do cosmetic suture? भैया इतना बड़ा गैप है, आप cosmetic suture करोगे उसका फेस ऐसे हो जाएगा. So let's get real. It's not possible. Similarly, for facial cancers, you have a flap which is called PMMC. Pectoralis major myocutaneous flap. Pectoralis major myocutaneous flap. So this flap contains skin of the chest, fat of the chest, and pectoralis major muscle, and it is taken from the chest, put on the face, but the blood supply, the artery, continues to go like this onto the face. So the artery is not disconnected. Artery will go from the chest, from the neck to the face. It's not in vicinity. How? Chest and face is not continuous, na? So how is it vicinity? They are distinct. If you take breast reconstruction is also done the same way. To fill the breast tissue, now look at it like this. I want to do a breast reconstruction. So your breasts here, and let's say I want to reconstruct this breast. So what I will do is I will take tissue from the lower abdomen. So I will cut some skin, some subcute, some muscle from here, this area, and it is being supplied by one artery. I take this tissue, take it underneath the abdomen, put it over here, take it underneath the abdomen, put it over here, and the artery that it was being supplied by, which was originally over here, will go like this. Now don't say this is also local. Abdomen with artery, I am taking to the chest. This is called tram flap for breast reconstruction. This is also pedicle flap. So basically, the tissue in these flaps, one part of the skin would be in its original place, other part cut. No, the tissue is taken from underneath the skin. Okay, it is taken from underneath the skin. Tear nahi hoga because you will only use arteries which have that much length, right? So जिसमें length होगा उसी में करेंगे ना. That's why they use tram, because they realize ये मसल की जो आर्टरी है वो लंबी है, उसको मैं खींच सकता हूँ. अगर नहीं खींच पाता तो मैं ये फ्लैप नहीं बनाता. It happens that during the surgery the artery does not reach, then it's a problem. It happens, then you have to put it back and think of something else. हो सकता है आर्टरी बहुत शॉर्ट है, नहीं पूछ रही ऊपर तक, क्या करोगे? Put it back from where you got it. That can happen. That's why the best thing to do is a free flap. Ideal. And it gives the best outcome. Free flap mein what is done is, let's say this facial cancer is resected. So now there is a big wound on the face. I'm not taking anything from the chest. What I will do is I will take tissue from the forearm. So I cut skin, subcute, some fascia, and a stump of the radial artery, like you see over here. I take that stump of the radial artery. So this tissue I take, this is disconnected. Okay, पूरा मैंने disconnect कर दिया. I put it on the face, and this artery, I join to artery on the face somewhere over here. Then maybe facial artery, I join it to the artery which I got in the flap. I do artery to artery anastomosis, vein to vein anastomosis. So now it is completely disconnected from the source, and I have done a vascular anastomosis. This is a free flap. In a free flap, you have to do vascular anastomosis. This not everybody can do. This is difficult. Artery जोड़ो, vein जोड़ो, तो कठिन, right? This flap that I described, this is called the radial free forearm flap. This is called radial free forearm flap. This is very commonly used for facial cancers, head and neck cancers. RFFF. So head and neck में ये बहुत use करते हैं. And if I want some bone also, I use this. This is called free fibular flap. So here what I'm going to harvest is going to be skin, subcute, muscle, and a piece of fibula. Because fibula I can cut. It is not weight bearing. I take some piece of fibula also, and then I put it where I want some bone. So if I have done mandibulectomy, commando procedure, and I want to fill the gap, I can use free fibula. So here also I'll have to do artery to artery anastomosis, vein to vein anastomosis, bone to bone anastomosis. Right? फिर रेडियल आर्टरी का गैप कैसे बनेंगे? यू कैन पुट अ स्किन ग्राफ्ट देयर. तो वहां पर स्किन ग्राफ्ट लगा सकते. क्योंकि वो बड़ा गैप नहीं है. But yes, question is right. There will be a gap. From wherever I harvest the flap, gap will be there. It has to be closed. Right? आई बात समझ में? Okay. So if they ask you best technique of reconstruction, best outcome, it comes from free flaps. They will give you the best outcome. Right? So that is about free flaps. Just see the whole what do you say, armamentarium of plastic surgeon. Vascular anastomosis is done by plastic surgeon, not vascular surgeon. ये करते हैं इंडिया में सब जगह में. Everywhere it is done. Because India has so many oral cancers. So everywhere you need an oncosurgeon to remove the oral cancer and a plastic surgeon to do a flap. Everywhere. So if you just do flaps na for oral cancers, बहुत है. Plastic surgery करो, सिर्फ oral cancer का reconstruction करो, more than enough. भरे पड़े हैं यार सब जगह oral malignancies. There are so many, and there are not enough surgeons to do it. Mukesh, yeah, Mukesh, who didn't make it. Right? So that was plastic surgery. Now we'll do some simpler things in general surgery that we must know, which is whatever topics were left behind. I think we are in good time, so we'll finish them. I think 15-20 minutes mein ho jayenge. What you see here, this is called a cystic hygroma. Okay, this is called a cystic hygroma. It is a developmental problem of lymphatics. So developmental lymphatic malformation. It is what is called as a sequestration cyst. Sequestration means lymphatic फंस जाते हैं during development. So it's a type of a sequestration cyst. This will be seen in neonate. So when the child is born, you will see it. And the most common site where it is seen is the posterior triangle in the neck. This cyst contains clear fluid, and this cyst shows what is called as brilliant transillumination. So that if you throw torchlight on it, it will really glow. That is called as transillumination. How will you treat this cystic hygroma? So treat कैसे करेंगे? Brain? No. Please remember, brain is for abscess. It's not for cyst. For cyst, anywhere in your life, your treatment will be excision. Okay, sebaceous cyst, dermoid cyst, cystic hygroma, treatment is going to be excision. Right? What is this interesting thing? Somebody yesterday was screaming in chat, ये topic कब पढ़ाओगे, ये topic कब पढ़ाओगे, ये topic कब पढ़ाओगे. Someone was screaming. So this what you see, this is the swelling in the floor of the mouth. This is called a ranula. It is seen in the floor of the mouth. Why is it seen in the floor of the mouth? What is the origin of this ranula? क्यों होती है? किससे होती है? It's because of you have those sublingual glands. One of the ducts of its glands will perforate. So sublingual gland duct ruptures. So it will form a cyst. So it is a type of a extravasation cyst because the secretions of the duct of the gland will leak out in the floor of the mouth. Remember, sublingual gland is also in the floor of the mouth. One of the ducts will rupture in the floor of the mouth and it will form a. So it is a extravasation cyst in the floor of the mouth. If it becomes very big, from the mouth, it can go into the neck. So it can go via the mylohyoid muscle. That is, there is a muscle between the mouth and the neck. That is mylohyoid. उस muscle के बीच से it can enter the neck. That is called as a plunging ranula. How do you treat this? What is the treatment of ranula? This will also be transilluminate. Yes, absolutely right. Excision. Anything else apart from excision? END. Keep open. No, excision is fine. Anything else you should do apart from excision in the same setting while you are excising the ranula? और भी कुछ करेंगे क्या? वो बता नहीं रहे हो. You're not telling the golden words. So this is also a transilluminant. Because it's a cyst with clear fluid, the treatment is excision plus removal of the affected salivary gland. So you will also remove the affected sublingual salivary gland. ओके सिर्फ रैन्युला नहीं, ग्लैंड भी निकालना पड़ेगा. तो इसके डक्ट्स में डिफेक्ट, इसलिए वो डक्ट ब्लॉक होके फूट गई. व्हाट इज दिस एंड व्हाट इज द ट्रीटमेंट? 2-3 times they have asked this question. Angular dermoid. ओके एंगुलर डर्मोइड लिख लो, जो भी ये लिख रहा था लिख लो. या दिस इज अ what is called as congenital angular dermoid or congenital dermoid cyst. This is seen in children normally at areas where the bones fuse. वहां पर होते हैं. Like you will see it at the canthus of the eye, you will see it in the floor of the mouth, you will see it in front of the ear or behind the ear. These are dermoid cysts. They are developmental malformations. Any cyst, the treatment will be excision. Okay. कभी भी ये वर्ड देखा ना आपने cyst, उसका आंसर will always be excision, not sclerotherapy or incision and drainage. IND is only going to be for abscess. Okay, IND ये वर्ड सर्जरी में abscess छोड़ के कहीं मत यूज करना, वरना कचरा होगा. Cyst excision, abscess drainage. ठीक है? Okay. Answer this. Very nice topic. This similar question also came in the exam. What is this? Patient underwent sternal cyst excision. After 1 year, he has this funny looking growth. What is the growth from the options? This is a keloid. So you need to know what is keloid, what is hypertrophic scar. Okay, important differences you should know. Keloid is nothing but they are both problems of scarring, abnormality in scarring. In keloid, there will be spread beyond the margin. So keloid will be like a cancer. There is one reel I have made on keloid. You can see it. It will spread beyond the margin of the wound. Hypertrophic scar will be within the wound margin. It will never spread beyond. It will be within the margin. So जितना भी injury है या जितना भी incision है, उसके around ही होगा. It will never outgrow like a cancer. Keloid will have itching. It will have pain. This will have no symptoms. Keloid will get worse with time. Hypertrophic scar usually improves with time. Keloid is typically seen in the sternal area, sternal triangle. Hypertrophic scar is seen on the abdomen more often. So someone who has had a laparoscopy, uske cuts pe you can get hypertrophic scars, right? Treatment for both is similar. You will use silicone garments to prevent. You will give injection of steroids like triamcinolone. Triamcinolone. So you inject it into the wound, into the steroid. Triamcinolone. And you can use some kinds of lasers, laser ablation. You can use the same for hypertrophic scar also. But normally, hypertrophic scar will get better. They will not be there forever. They will fade with time. Keloids will get worse. So keloid is a problem. Okay. On arms, legs, which scar, sir? That is a hypertrophic scar. This one. Keloids typically on the sternum or earlobe, and they are seen at sites of ear piercings. What is this? ghastly looking thing where all the skin and everything is stripped on the hand. This is what is called as a degloving injury. Degloving simply means when there is a trauma, the skin and the subcutaneous fat gets stripped. So skin and subcutaneous fat gets stripped or gets degloved. जैसे ग्लव निकालते हैं ना, वैसे स्किन और सबक्यूटेनियस फैट का चमड़ी जैसे उधेड़ दे. So what you will see visible will be the muscle or the deep fascia. All this will be visible. So muscle, deep fascia will be visible. In this case, you see the tendons. So they can ask you, okay, when do you say it is degloving? Degloving means skin and subcute both have to be stripped. Again, a topic which has been asked quite a bit, that is pressure sore. You commonly call it as bed sore or decubitus ulcer. How much pressure is required, PYQ, to get a pressure sore? कितने pressure पे होगी pressure sore? It should be consistently more than 30 mm of Hg. This is seen in people who have neurological problems, stroke, who are bedridden because of continuous pressure. Most common site, yeah, it is going to be ischium. Okay, it's not sacrum, it is ischium followed by greater trochanter. These are the two common sites. So MCQ में ये भी पूछेंगे, most common site ischium followed by greater trochanter. And then you should know the grades of pressure sores. In grade 1, there is non-blanching erythema. So skin is intact. There is only some erythema, some redness. अभी तक कुछ भी कटा नहीं है. अभी तक वो pressure injury में कुछ कटा नहीं है. There is no ulcer yet. Pressure for how? There is no time. It's not time based. It can vary from person to person. It is over a period of time, but there should be consistently 30 mm Hg jitna pressure. So you can't say 1 day, 2 days, 3 days. It is variable. In grade 2, there is partial skin loss. In grade 3, there is full skin loss. So you can see the fat. Fat is visible. And in grade 4, other structures are visible, like muscle, tendon. That is going to be grade 4. What is this grade of pressure sore that you see in the image? Yeah, this is grade 2. Because fat is not seen. Some amount of skin is still intact. So it is grade 2 pressure sore. Okay. Answer this. See, they ask these kind of questions. That's why you should know. Otherwise, they are very straightforward. 30 mm of Hg is the answer here. Answer this. Another PYQ, since we are doing wounds. Sequence of treatment in lady with burns to the neck and lower back. Debridement, resuscitation, autograft, whatever. How are you? What is your order of priority of management? So obviously, you will first resuscitate. So A and B options are out. And obviously, reconstruction will come last. So resuscitation, debridement, reconstruction. Common sense. ऐसे क्वेश्चन आते हैं, फिर भी आप लोग बोलते हो सर इतने टफ पेपर, पेपर पार्ट 2 was tough, was easy. Surgery questions you have to get right. Okay, out of 30 questions, 35 questions, you should get 27, 28 right. Then your exam is sorted. बाकी जगह पे हाथ पैर मार लो, हो जाएगा 150 मार्क. ऐसे ही हुआ आपके सीनियर का. Whoever I have spoken to, I understand that, but if a few subjects you master, it will really take your burden off. You cannot master all 19 subjects. So you go two ways. Sub subjects है थोड़ा थोड़ा करो, but that's taking a chance. Or master some and get thoda thoda from the other. I think that's a better bet. Easier way to cross over, because questions are tough. They are not as easy as we thought. So this blade, 11 number blade, this is called stab knife. It is used for incision and drainage. So I and D के लिए आप 11 number use करेंगे. It is also used for arteriotomy. When I want to open an artery, I use 11. This 12 number blade is used for suture removal. So I cut a suture to remove it with this. 15 number blade is for minor surgeries to cut the skin. And these nice big blades are used for laparotomy, thoracotomy, all that. Okay. Normally they ask on 11 number or 12 number. Normally. Answer this. What is this technique of suturing? Arteriotomy. Arteriotomy means puncturing the artery. Otomy means to cut open. Arteriotomy. So what you see here is the suture starts from here. Then it is not seen on the skin. It is all underneath the skin. It's all underneath the skin. Underneath the skin. You don't see the suture. Only you see it enter here and come out here. Only entry exit. बीच का तो कुछ नहीं दिख रहा. This is a subcuticular suture. Okay. You were saying interlocking. Lock कहाँ है इसमें? It's a continuous suture, but it's not locking. This is a subcuticular suture. This is a very cosmetic skin suture. Okay, subcuticular suture. I'll show you some of the sutures. Have a look at this one. You see, it looks in the shape of a square box. Looks like a box. You can see over here. Looks like a box. What would you call this box? It looks like a box. This is called a box stitch. इतना मैं 10 बार बोल रहा हूँ. Box, box, box. Also called as horizontal mattress. So if it looks like a box, it's a horizontal mattress. Okay, what is this? Something very unique. Horizontal mattress. What is the next one? This is continuous suturing. So this is a continuous suture, you can see. But at the end, the person is tying a knot with the same suture. He's throwing a loop and tying it out. This is called Aberdeen knot. The type of the knot that you see here is called a Aberdeen knot. End of the suture is tying with itself. That is called Aberdeen knot. It is used in continuous sutures. ये तो आसान है. I am guessing ये आपने पढ़ा होगा. Square knot, also called as secure knot, also called as reef knot. This is the knot that is normally done when we do surgery. It is a secure knot. It will not slip. How do you identify it? You see the loop and you see the two ends going through the loop. What you notice here, both ends are going below. On the other side, you see the loop. Both ends are going above. Both ends are above. Here, both ends are below. So it's a square knot. In a granny knot, you see this loop. One suture is going above. One suture is going below. Alternate. This is granny knot. In granny knot, the suture goes alternate. In square knot, both the ends go on the same side. Okay, that is a square knot, also called a reef knot, also called a secure knot. Granny knot is an insecure knot. Square knot is a secure knot. Square knot is also called a reef knot. Okay. Surgeon's knot will have many throws. So surgeon's knot will have many more loops. Surgeon's knot is made with a needle holder. So you can see, first we take 2 throws, then we tie. So you get so many loops. Then you take more throws and you tie, then you get more loops. So in a surgeon's knot, first you get 4 loops. 1, 2, 3, 4. Then you get 2 loops. If you have done internship, you'll know. ऐसे करके बांधेंगे 4 loops. ऐसे करके बांधेंगे 2 loops. So this is surgeon's knot. This is what we do when we are doing normal suture. Okay, this is a PYQ. If you are undergoing a surgery, when should the hair be removed? Like if I am undergoing laparotomy, कब मेरे को स्किन की माल निकालने चाहिए और कैसे? So ideally, you should not shave, and ideally it should be on table. कोई करता नहीं है ये, but this is ideal that you should use trimmers on table. Don't do shaving, because when you shave, you can cut the skin a little bit, right? And last topic, then we'll be done. That is TPN. TPN stands for total parenteral nutrition. When is this used? Total parenteral nutrition. When it is used, how it is used, and what is this funny looking thing? So this is used in a patient who will not take orally or not take any enteral nutrition for more than 5 to 7 days. This is normally going to be seen in people with GIT diseases. They will need TPN. So someone who has a GIT disease, like a short bowel syndrome, उन patients में आपको TPN देना पड़ सकता है. Okay. Or if he's going to have prolonged GIT problems, enterocutaneous fistula, maybe in these kind of patients. But let me tell you, TPN is the last resort. It is the worst kind of nutrition. Best nutrition is from mouth. If you can't give by mouth, give from nasojejunal tube, give from feeding gastrostomies, intestinal feeds. Enteral feeds are good. TPN is the worst. TPN is given directly into the neck veins. So normally you give this nutrition in the neck veins, most commonly in the IJV. So you have to put that catheter, triple lumen catheter, in the IJV. Ideally, it should be put in the subclavian. Ideal vein, subclavian. This is what you are seeing. This is the TPN bag. This white part, you can see lipid. This part, amino acid, glucose. So it has lipids in one TPN bag. There will be lipids, maybe about a 1 liter bag will have dextrose. It will have lipids. It will have amino acids. So it's a special solution. It's not like your normal saline, vagara, vagara. It's a special solution. It is expensive. And you have to give this every day. So for as long as you are going to give TPN, you have to give this TPN every day. One new one. One TPN will cost 1,500, 2,000 rupees. So it's not very easy. And the worst thing is it has many complications. Complications बहुत हैं. The most common complication that you will get is the line from which you are giving TPN gets infected. That is called catheter sepsis. Most common complication, catheter sepsis. During insertion of the neckline, you can get pneumothorax. Please understand, if I am giving nutrition directly into a vein, I have no control. Whatever I give, the body gets. Why do I need GIT? GIT can control. If I overeat, it will vomit. If I eat some wrong things, I will get diarrhea. There is a control in my GIT. It is so many meters in length. That control is not there in TPN. जो आपने दे दिया, जो nurse ने दे दिया, वो गया. Which means you can get overfed. So you can get problems of overfeeding. So you can get hyperglycemia. ज़्यादा sugar content मिल गई. You can get fatty liver. You can get fluid overload. बहुत fast दे दिया. कंट्रोल नहीं है ना. जो टीपीएन बैग में है वो पेशेंट को मिल गया. अगर उसके लिए ज्यादा हो गया तो क्या? Or he can get deficiencies because it will not contain everything. So he can get deficiencies, micronutrient, zinc, iron, and so on and so forth. And there is one life-threatening problem which is called refeeding syndrome. What is this refeeding syndrome? This happens rarely, but it can happen, and it is life-threatening. What is this refeeding syndrome? किसमें होती है और क्यों होती है, और इस पे एमसीक्यू आएगा इस बार. What a nice question. ये गंदा मसाला ही है ना. So if a person has been chronically starved, बहुत दिन से उसने खाया पिया नहीं है, so in these patients all their biochemical cycles are एकदम toned down. So your Krebs cycle, glycolysis, they are all very toned down. If I will give him suddenly if I start giving him feeds, so what will happen is all the cycles will get upregulated. There will be a sudden increase in ATP production, and because of this ATP, the person will have low phosphate, low magnesium, low calcium, low potassium. This was asked. One of the options was hyperkalemia. You get hypokalemia. And because of this, the person will have CVS and CNS problems. It's because of these deficiencies acutely. So this has to be avoided. Anyone who's chronically starved, you should give a gradual feeding. All right. So this is the main thing that you need to know about refeeding syndrome, right? So we have covered many things. I am glad we covered everything today. So I will see you on Saturday, where you will get about 75-80 questions to discuss at 5 o'clock. Shock should be covered in medicine. It's not really a surgery topic, to be honest. Yeah. So don't worry about shock. Why not marsupialization? You can do marsupialization. It's not necessary. Hemorrhoids, I'll do in END. So hemorrhoids, Meckel's diverticulum, they will be done in END. HCC nahi aayega exam. I don't think so. Okay? So, okay guys, have fun. Enjoy yourself. Keep studying very hard. Remember, if you can get 25 to 30 questions in surgery right, burden of other subjects will reduce drastically. So prepare surgery and other clinical subjects well. All the best, guys.